Hello everyone, welcome. This is Claire Harrison on behalf of the Guys team, many of whom you can see on the screen. We're just waiting for people to join. Just bear with us a few minutes and we'll get going. We're getting very good at these Zoom meetings now. Hopefully we won't be chancing our luck too much.
Famous last words.
Yeah. Exactly. So, we good? Yeah, great. Okay, well, let's get going, and we hope we've got a really exciting programme for you this afternoon and this evening. It's very nice to see people I recognise on the screen. Hello, everyone, and hello from the team at Guy's and St Thomas's. The technical team in the room have done a fantastic job already, and we're really pleased today to be joined by colleagues from Italy, Professor Vannucchi, and also colleagues from Ireland, Professor Anderson and Professor McMullen. And I'm also really grateful to several members of the Guys team who are joining us today at the end of a busy day, but also some of them are on holiday but still dialing in to be part of this forum. So welcome from the team. Right here in the heart of London. And just a few housekeeping slides before I hand over to Jon, who's going to do the MPN Voice introduction. So it will help us later if you can adjust the settings on Zoom to ensure that we've got the right first name and last name showing. This is good when it comes to actually chatting, but it's also helpful for Danny, who will be moving you into the right breakout group. And instructions to do that will be posted in the chat. Just occasionally we have people joining with their children's devices, etc. So just make sure you've got the right name. There is still a chance to submit questions to the panel, and I would encourage you to do that. We'll try our best to answer questions during the event, and if we can't answer them, we will try to answer them afterwards. But please remember, we can't really safely answer any questions about your personalised sort of treatment or treatment plan. If you can, please try to remain on mute during the talks and when you're not speaking during the breakout group session, because we will probably have around 140 or so people with us this evening. We're already well up over 70. And please also do fill out the feedback survey, because we would like to know how to do these kind of things a bit better. We know you're super great at filling out feedback, and we're going to see some of the data from some surveys, etc., a bit later. So at this point, I'm going to try and change to the next slide, which I can't do at the moment. So that's our one technical glitch, right? Here we go. And I'm going to hand over to Jon, who's just going to talk us through the agenda. Jon.
Thank you very much, Claire. Claire, can you just nod if you can hear me?
Yes.
Fantastic. That's great. I had a few technical problems last time I did this, so it's reassuring to get a bit of feedback on that. Thank you. Thanks again, Claire, and thanks again to everybody else who's contributed to making this happen. If you haven't heard of me or you don't know me, my name's Jon Mathias. I'm the co-chair of MPN Voice, which means I don't really do very much. I just kind of get to talk to you on days like today, and then let people like Maz do all the work. So our agenda this afternoon, as Claire says, I think we've got a really, really good set of talks coming up. Just lost the agenda off the screen.
Screen sharing, so we're just going to stop. Somebody accidentally pressed a button. There we go.
Fantastic, that's better.
See it.
Okay, so we're going to start off with a talk by a group of doctors, Patrick Harrington, Jamie Saunders, and Donal McLornan, talking about COVID. So it's appropriate enough, given where we are in the history of the human race, I suppose. We are then going to learn about the Mosaic study, which I know those of you who've been following MPN Voice for a while will know that this is a study that we began getting involved in many years ago, and it's now beginning to gather momentum. And Professor Anderson and McMullin are going to give us an update on Mosaic, where we've got to. And for those of you who don't know anything about it, you'll be able to learn all about that really, really important piece of research. Claire Woodley from Guy's, who's a clinical nurse specialist at Guy's, is going to give us a talk about tracking symptoms. This is another very, very important topic, and it's particularly important to people like me, in fact, and I may get the opportunity to explain why that is when we talk a bit more about advocacy. We're very, very privileged to have Professor Vannucchi from Italy joining us this afternoon, and he's going to give us a historical view of MPN when these disorders were discovered, or at least described in the first instance, and how our understanding and our development of therapies has developed over time. We then have our patient talk, which is from Maz. I know a lot of you will know Maz's name, and you may well have seen her at our events in the past. Many of you may not know Maz's personal story with her MPN herself. And she's joined today by Mark Taylor, who's recently volunteered to help us a lot with social media work. We then have a Q&A session, and we have a large number of questions that have been submitted in advance. But even if you haven't submitted a question in advance, please feel free to ask any questions. I know that when I go through the intro bit, you'll find that I don't say everything that's on every slide. And if there's a bit that you wanted to ask about, please ask your question in the chat function in Zoom, and we'll try to get round to answering it during the Q&A. If we don't manage to get to your question, whether it was submitted in advance or during the talks, don't worry, we will do our very best to answer your question after the forum in an email that we will send to all the attendees. We'll take a quick break. Hopefully this will be at around 20 to 7 for obvious reasons. And then we have when we come back from our break, we'll break into our different breakout groups. Don't worry about the managing Zoom during that process. It all gets done for us. And by the process of magic, or I should say Danny, we will end up in the appropriate breakout group. And then we'll have a brief opportunity to come together at the very end just to wrap everything up. So, as Claire said, a really, really good agenda this evening. Claire, can you go on to the next slide? Thank you. So, very brief potted history of MPN Voice. So we came together in 2003, and that's a really amazing number to me because it seems like it was just a couple of years ago. 2003, getting on for 20 years ago. A group of patients, hematologists, nurses and psychologists got together, and I think our first meeting, well, apart from a kind of a round table around somebody's kitchen table, was a meeting that we had at the top of the Guy's Hospital Tower. And there, I seem to remember there being about maybe 10 or 15 people in the room at that time. We've obviously gone on to do bigger and better things since then, but that's when we got started. Claire Harrison's was really the instigator of it all, and we're eternally grateful for the energy and the expertise that she's committed to the group ever since then. I'll stop embarrassing her now. Okay, very quick slide on how we're organized. So there's a group of volunteers alongside Claire who essentially kind of try to do most of the sort of major decision making, but we're supported by an amazing group of people who run the management committee, a fundraising committee. I know that Maz will be talking a lot about fundraising in her talk, and we're extremely lucky to have a really excellent panel of doctors doctors and clinicians generally, who can support our work in everything that we do. Next slide, please, Claire. So over the past 18 months, MPN Voice has done our best to help patients deal with the additional burden of living alongside COVID. I know at the very beginning of the pandemic, we realized that this was going to be something that was of enormous concern to MPN patients, whether it was because of their conditions themselves or possibly because of the treatment they were having, and they wanted to know how much that would affect them, and were there any particular kind of things to bear in mind about avoiding infection, etc. I'm very proud of how the team came together in that first instance, and we've continually tried to put out tailored information that goes beyond the standard sort of NHS or government provided information, which is specific to MPN Voice patients. We also started a sort of an emergency fundraising exercise at around that time, because we immediately realized that we wouldn't be able to do any face-to-face fundraising. And I'm very grateful to all those people who put their hands in their pockets at that time and made up some of the shortfall that we had in fundraising last year. One thing I'll say now, I might come back to this later as well. You will, as MPN patients, especially those of you, sorry, I'm just going to mute this phone. Sorry, especially those of you who are on the MPN Voice mailing list, email list, you will get a lot of requests to participate in surveys. And I know this can be probably a bit burdensome sometimes, but one thing I would say is that MPN Voice is like an interface, if you like, between researchers and the patient community. And one of the most important things that we can do is essentially gather information from our patient community and pass that on to the various different research studies which are taking place. This is a really important function, and I know it can be a bit of a pain getting yet another link to a survey, but it's a really important thing that we try to do, and the information that patients provide research studies through this process is one of the main tools that we have at our disposal to make that research effective. So next time you get a link to a survey, please just take 5-10 minutes to fill it in. Thank you very much. Next slide, please, Claire. Okay, from the word go, MPN Voice has been, its number one priority has been providing up-to-date, accurate and informative information for patients. We started with leaflets, and we still provide those. We know that not everybody wants to spend all of their days on Facebook and Instagram, etc. We still provide printed information, but our website is now in its, I think, third iteration. I think it's an excellent resource, especially for people who are recently diagnosed. And increasingly, we're doing more and more work on different social media platforms that I know Maz and Mark will be talking about later. Next slide, please, Claire. So our face-to-face forums are probably the most visible kind of activity that we historically have done. Okay, and you've got a list of all the different cities in the UK there that we have visited over the years, and we fully intend to keep visiting these cities and more when we're allowed to. In the meantime, we're doing events like the one that you're attending this afternoon, but it'll be great to be back on the road, meeting up with patients and providing forums for patients to meet each other. We have learned over the years that the opportunity for MPN patients, especially those who are recently diagnosed, to meet other MPN patients is a really, really powerful thing. It's almost therapy in itself. And the sooner that we can get that going again, we will be doing exactly that. And I think I'm right in saying that the first face-to-face forum that we're planning will be in Dublin next year. I can't honestly remember, but we'll be getting going as soon as we can. But I think it's a pretty impressive group of statistics you can see on the slide there. Next slide, please, Claire. Okay, so in addition to people coming to all those cities around the UK, it turns out that people really like attending MPN Voice events from all over the world. And you can see some of the places that we have attendees dialing in from those countries. I wonder whether we've got any new countries to add to that list this afternoon. We'll see when we do the analysis of the joinees today. But it's a source of pride for us that we're able to reach patients around the world. And it's also a source of pride that we've been able to help patient groups get started in many countries around the world. We know that the information that our doctors provide on our website, for instance, has been used to create patient websites in lots of different countries since we started. So this is a fantastic reach that we've been able to achieve. Next slide, please, Claire. Okay, so I'm going to very, very briefly talk about a bit about research. You'll see a few details about a couple of specific programs on the next couple of slides. We have been lucky to be able to support different research projects through partial funding of some research projects. But I think one of the most important things that MPN Voice does is it provides that connection, as I said before, between the patient community and researchers. So even if we're not able to directly support research through funding, one of the things that we can do is engage the patient community and get them involved in, for instance, the way that research studies are designed in the first place, gathering information from the patient community to help the research, etc. And you have on the slide there a few of the programs that we've been able to support over the years. Thank you, Claire. Here's a specific one which is ongoing at the moment, a study called Mithridate. You'll see that most of these research programs start with the word M. I guess that's the same as the M for myeloid, but anyway, so Mithridate is a study which compares ruxolitinib with best available therapy. It's been going for quite a while now, I know. Next slide, please, Claire. Mosaic, which you're going to hear a lot about in the next half an hour or so. I won't dwell on that one. And three particular pieces of research around coronavirus are ongoing at the moment. So a a study that Claire was involved in, looking at the response of MPN patients to initial infection, the response to patients when they underwent vaccination, and the effectiveness of that vaccination are all pieces of research which have come out of Claire's team in London. Next slide, please, Claire. This is my slide, the only one of the ones in this deck. So one of the responsibilities I have in MPN Voice is to essentially represent patients as what we call an advocate. And this happens in a number of ways, but one of the most important ways is representing the patient view when it comes to the decisions about whether or not new drugs will be funded by the UK government. We do that in three contexts, really. Firstly, by submissions to the organisation known as NICE. I'm sure many of you will have heard of NICE. They essentially make decisions about the value for money of different therapies. The equivalent organisation in Scotland is called the SMC, and we've done a couple of submissions over the past couple of years to the equivalent in Ireland called the NCPE. We're very, very reliant on information from the patient community to help us in those efforts. And that's one of the areas that patient surveys have been particularly important over the years. I also represent MPN Voice in an international advocacy group where different patient groups come together from around the world, and we share best practice, and we have a think about what the most important priorities are for MPN patients around the world, and we help patients establish patient communities in their own countries. And that's been a group that I've been involved in for the past 10 years or so. And I think we're coming up to the last slide now, aren't we? Yeah, I think so. So last couple of ones from me. The ongoing support of the patient community to MPN Voice is absolutely vital. Maz will be saying a bit more about fundraising in her talk, but the last message from me is really, firstly, thank you very much to all the patients who and their families and their friends and their colleagues at work, etc., who have supported MPN Voice over the years, and in particular at this time when it's difficult to do our traditional fundraising. Any money that you can provide for us is really, really extremely appreciated. You can donate by going to the MPN Voice website, and I think there's a fairly prominent link on the front page of the website to help you do that. If you want to get involved in fundraising, and I'm sure Maz will remind you about this again, there's a particular email address that you can see on the slide there. And I think that's it for my intro bit. I'm sorry if it took a bit longer than we were planning.
No, that was great, John. Thank you very much. So we're going to move now to talk about COVID. It's a banned subject in my house, actually, but it's obviously a subject that's really important. And we've got three speakers, starting with Donal McLornan and Patrick Harrington and Jamie Saunders, who are going to speak about what we know about immunity, vaccination, and responses to vaccines. So super grateful that they're here, and I can see they're ready to start now. So over to you, Donal, who's really been coordinating this work. So thank you and congratulations.
And thanks so much, Claire and John and Maz. So thanks for the opportunity for us to talk today on some of our updates on some general comments about COVID and immunity, in addition to some work that we've been coordinating through Guy's Hospital research team with the support of MPN Voice. So there are three sections to the talk today. I'm going to give us a very brief top-level overview of what the immune system actually is and how vaccines work, which will give us a background for Patrick, who is one of our senior research members and clinical hematologist within our MPN team, to talk about the work on responses in patients with MPN to COVID vaccination and also to natural infection. And then Jamie, who is one of our members of our MPN team, a physician associate, will talk about the survey that many potentially of those on the call were involved in, looking at real world experience of patients who have an MPN and their experience with vaccination. So as Jon has already alluded to, there are three major pieces of work that MPN Voice has very gratefully helped us with within GUISE. And one of them is looking at response to natural infection. So this is the first piece of work, looking at how the immune system responds in patients who have an MPN when they encountered COVID. The second really important piece of work was looking at MPN patients and how they responded and what their experience was to COVID vaccination. So did we see any worsening in symptoms, and what was the actual reality of having a COVID vaccination alongside managing an MPN? And thirdly, looking at a very important piece of work, which is effectiveness of vaccines. And the first piece of work that has already been published focused on the Pfizer vaccine and response after first dose, and Patrick and the rest of the team are currently looking at responses after second dose. So as all of us have heard, I mean, we've been into this now into our second year of dealing with COVID. So COVID is a very pleiotropic disease. It can manifest ranging from being entirely asymptomatic right through to very severe and debilitating disease. We all know the cardinal symptoms of COVID as regards cough, as regards fatigue, fever, loss of taste, loss of smell, but it can affect any organ and system. Up to about 25% of patients may experience gastrointestinal, so gut symptoms such as nausea, vomiting. There can be cold type symptoms, sore throats, headaches, and often it can be a mild and self-limiting disease, but in a proportion of patients, as we know, unfortunately, it can have very severe presentations with acute respiratory distress syndrome, neurological complications, and unfortunately in some multi-organ failure. So the immune system is a really clever, complex network of cells, tissues, and organs, in fact, that work together to defend the body against foreign invaders, including viruses. It's amazingly complex. It can recognize and, most importantly, remember millions of different enemies and can adapt, and that's called the adaptive immune response, to mount effective defenses. And it really relies on, which is most important for all of us, very effective communication. In brief, it is divided into what's called the innate immune system and the adaptive immune system. And when we talk about the adaptive immune system, and Patrick is really going to focus on his results, looking at responses to vaccination, we can divide it into two main parts, and they are called B cells or B lymphocytes and T lymphocytes. And lymphocytes are really pivotal, important members of the immune system, and around 70% are T lymphocytes and about 30% are B lymphocytes. All of us will have heard about antibody responses to vaccination, and mature B cells are called plasma cells, and those are the cells that actually produce and maintain the antibody response. And importantly, one thing we're very interested in as regards durability is how long do those antibodies last for? And what's the sort of proportion of these plasma cells that are called memory plasma cells? So they have a memory that if they meet COVID again, they can mount an adequate response. The counterpart of the B cells is the predominant population called T cells. And they can be divided into two main populations. There are many complex subtypes, and they're called T helper cells and cytotoxic T cells. The helper cells help coordinate the immune response. They have a pivotal role themselves, but also can prime the B lymphocytes. And the cytotoxic T cells are like the army of cells that can attack and destroy viral infected cells. So this schema shows us an example of what the immune system hopefully does when it encounters COVID. And this is called the humoral immune response. So here we see a pictorial representation of the COVID-19 virus. It is an RNA virus. It has an envelope and it has spike proteins. And that is what the vaccines were generated against. It enters into the cells, the host cells, and it really harnesses, it's like a parasite, it harnesses the machinery within the cell to allow virus replication and propagation of the virus. The virus is then released into the system, and in order to mount an adequate immune response, part of the virus is processed, it is presented to the immune cells, and here we see both the helper T cells in addition to B cells coordinating an effective immune response. And in order to neutralize the virus, we need not only an antibody response, which is often a complex response of many different types of antibody to various components of the virus, but alongside it, a T cell response, not only to help destroy viral infected cells, but importantly, to have an effective memory if the person who's met COVID or been vaccinated would meet the virus again. And this summarizes the T cells, which is a really important part of our work that we focused on in GUISE with the support of MPN Voice, and how they can help prime the B cells, and in addition, help clearance of the virus. Because really, when we're thinking about meeting COVID, we know that there are many, many individuals who've had COVID who've been entirely asymptomatic. Here, both parts of the immune system have led to effective viral clearance. There's no large-scale hyperinflammation, and there's complete resolution of the viral disease. And importantly here, we hope that there's an effective viral memory. In mild to moderate disease, this immune system gets primed, we get production of antibodies, we see an effective T cell response, and both of these parts of the immune system together lead to effective viral clearance and ideally resolution of the disease. But as we all know, some individuals have severe COVID. Here we see often very marked inflammation as the body's immune system tries to combat the invading virus. We see uncontrolled hyperinflammation, and really there's no break for that inflammation, so it continues. We see that the components of the immune system become exhausted, and importantly, that can affect the T cells. And then we get the unfortunate situation that we have very active viral activation. We get organ damage from the inflammation without resolution. And it's very important for us to understand how the immune system can be augmented through vaccination to combat severe disease. So just in summary, B cells are antibody-producing cells. The plasma cells are the mature cells that produce the antibodies. And most importantly, what we want to look at are memory cells that remember the offending virus. T cells are just over 2/3 of the lymphocytes, divided into helper and cytotoxic T cells. And importantly, we've also looked at memory T cells. So what these T cells can remember from mounting that initial immune response or how they've responded to the vaccine. Vaccines are complex medications. There are many different types of vaccinations, as you know, that have been developed rapidly against COVID. There are 4 which are licensed within the UK. These are the Pfizer mRNA vaccine. It's been shown to be over 90% effective in those over 65. As you know, it's approved in the UK use, and it's including those who are 12 to 15 years of age, and delivery is ongoing. The Oxford AstraZeneca virus is called a viral vector virus. It uses an adenovirus vector. On average, its efficacy in the phase 3 trials globally was just over 70%, again approved in the UK, and there's some query whether those who are less than 40 years of age should be offered an alternative. Moderna is a relatively recent introduction, approved in the US and the UK with over 90% efficacy. And the Janssen vaccine has not been used that much yet in the UK. It is a one-shot vaccine. It's been approved, and there's a query whether the booster jabs that will come later this year will be the Janssen type of vaccine. One last study before I hand over to Patrick, a really interesting study, and this focused a lot of the questions that we've seen submitted based on vaccination, and I look forward to the discussion later in the panel. But one of the questions is really, what is the best type and combination of vaccination strategies? And we're currently learning about this. So this is a really important study called the COMCOV study. That's a population-based study in the UK. It included adults over the age of 50, including those with well-controlled medical disorders, who were randomized into 8 groups, who received 2 doses of vaccine, either at a 4-week gap or at a 12-week gap. And really, in brief, it looked at using 2 AstraZeneca, 2 Pfizer, or mixing up Pfizer and AstraZeneca in a different order. We have much more to learn about scheduling. And really, the first part of the study has just been published. It looked at 850 of the UK population who had doses 4 weeks apart. Very interestingly, the AstraZeneca followed by Pfizer induced higher antibody responses than the reverse, so Pfizer by AstraZeneca. Both of these mixes, so mixing up Pfizer and AstraZeneca, so 2 different types of vaccine, induced higher antibody responses than AstraZeneca alone. And the highest antibody response was seen after 2 doses of Pfizer, whereas the highest T-cell response was seen after AstraZeneca followed by Pfizer. And really, I wanted to show this slide just because it's really a big question for all of us about really what's the most effective strategy and type of vaccine. And there's much more for us to learn from these type of studies based about scheduling and type of vaccination. In addition, what is the correlates of protection? And by that, I mean, there is no specific cutoff of T-cell response or antibody response that tells who is importantly affected and how long that protection can last for. And that's really what we need to learn of over the next 6 to 12 months. And with that, I'd like to hand over to Patrick. Thank you very much.
Thanks, Donal. Let's see if I can share my screen.
Barking in the background, Donal. That's not my dog.
It wasn't mine either.
It's one outside in the courtyard. You good to go, Patrick?
Sorry, let me just see. Is that sharing?
We can see your title slide.
I think that might be me still, is it? Yeah, it's me, Patrick.
I think it might be blocked, the sharing function.
I can stop sharing. Sorry, Patrick. Yeah, that should be it.
Okay.
There we go.
Can you see that?
Yeah.
Great, okay. So following that helpful overview, I'm going to talk about the specific immune response to infection and vaccination in patients with MPN. So as we all now know, COVID-19 has caused unprecedented global healthcare challenges, and the key to controlling the pandemic is through development of antiviral immunity, either through infection or preferably through vaccination. So the key questions we have currently from an MPN perspective are whether patients with MPN are at an increased risk from infection with COVID-19, whether patients with MPN will respond adequately to vaccination, and following on from this, as Donal mentioned, what level of antibody or T-cell response provides adequate protection. So I'm going to discuss some of the data that we have to answer these questions, both from our own research and from other groups. To start with some background information, we know that the immune system can be affected both by the underlying diagnosis as well as certain treatments used in MPN. However, we recognise that this varies significantly from patient to patient. The question as to whether patients with MPN are more affected by infections generally has been addressed recently by 3 large studies. Firstly, a study from Sweden compared incidence of infection in over 8,000 patients with MPN, and this was compared to that observed in healthy individuals. And they found that both bacterial and viral infections were significantly increased in the MPN patient group. Following on from this, a study evaluating over 1,000 patients identified diagnosis of myelofibrosis as well as treatment with a JAK inhibitor, ruxolitinib, to be particular risk factors for developing infections. And finally, another study specifically looking at patients with myelofibrosis diagnosis, again found ruxolitinib treatment as well as high-risk disease as per the IPSS scoring system to be particular risk factors for infection. So moving on to discuss whether patients with MPN are at increased risk from COVID-19. And thus far, 2 studies have really been published that provide data on this subject. Firstly, a study that was led by the Italian MPN specialists, and this looked at outcomes in 175 patients, and they reported a survival rate of around 70%. So this would suggest a significantly increased risk compared with the general population. However, we need to note 2 very important factors regarding this study. Firstly, this data was from the first wave, of COVID-19. So it was prior to the implementation of vaccines, which we would of course hope would significantly affect this data. And secondly, the nature of these studies is that they're retrospective in nature, and they come from the haematology specialists who report their data. So they're very much likely to be skewed towards more severe cases. Many patients with MPN will have mild infections, and their haematology team will not be notified or made aware of their infection at all, which introduces some bias in the reporting. With regards to the individual risk factors from infection, the usual factors were observed, with age, male sex, and ICU admission all identified as presenting an increased risk for patients developing COVID-19. However, probably the most important finding was that patients who had ruxolitinib therapy discontinued had significantly worse survival than those who had this therapy maintained. And this is shown by the graph on the right. It may be that ruxolitinib helps to control the inflammatory syndrome that Dr. McLornan mentioned that was observed in some patients with very severe COVID-19 infection. And the second study to report on outcomes, which I'll just briefly mention, was a UK physician survey. So again, reporting outcomes from haematology specialists. And it looked at 77 patients. And here they found no difference in outcomes across the different MPN subtypes. So moving on to the specific immune response to COVID-19 infection. Our colleagues at King's College London, who we've been working very closely with, who are experts in virology, published a very important article that showed that antibody levels declined significantly in the first 3 months after infection with COVID-19. In view of this report, we focused strongly on the T-cell response to infection and vaccination. And there's also some quite convincing evidence from the SARS-CoV-1 epidemic that T-cells play a particularly important role in immunity against these coronaviruses. So we were able to show, using a special technique called flow cytometry, that there was presence of specific T-cells that reacted to 3 different proteins from the SARS-CoV-2 virus, including the spike protein that's used in vaccines, that's targeted in vaccines. So at over 6 months after infection, these specific T-cells were still detectable. And this is shown by the figures on the right. I'll just get my pointer. So this is shown by the figures on the right, where each tiny dot represents an individual T-cell from a patient with MPN. The plot on the top left here shows unstimulated cells that were not exposed to the virus proteins. However, the other 3 plots show a significant reaction when cells were exposed to each of the coronavirus proteins being studied, as signified by the cells in the outer quadrant shown here, showing a significant reaction. And this was the first data showing this in an immunosuppressed population internationally, so we were quite pleased to report this study. So moving on, we then began to focus on the response to vaccination in collaboration again with our colleagues at King's College London. We studied the antibody response initially in 21 patients after the first dose of the Pfizer vaccine. 7 of these patients were undergoing watch and wait treatment and active surveillance. 6 were taking ruxolitinib, 4 were taking hydroxycarbamide, and 4 were taking pegylated interferon. To strengthen our research, we used 2 techniques to assess for an antibody response. Firstly, we performed a standard quantitative anti-spike protein antibody test. And then we also assessed for the presence of neutralizing antibodies. So this is a functional test which actually assesses how well antibodies in patients' plasma prevents the entry of a virus that's been engineered to express the spike protein from entering cells. This is all done in the laboratory. We found that there was a positive response to vaccination in 76.1% and 86% of patients using these 2 methods. And we also observed significant correlation between the results from the 2 tests, as shown by the figure on the right, which is reassuring from an analytical perspective. We didn't observe any difference in the antibody response across different diagnostic or treatment groups, other than that higher levels of antibodies were observed in patients with myelofibrosis. However, this was likely explained by more of these patients having evidence of previous COVID-19 infection prior to vaccination. Another study looking into this was reported by the Oxford group, and they looked at, again, the quantitative antibody levels in 60 patients, including 35 patients who had a diagnosis of MPN. And again, this was analysis performed after the first dose of a vaccine, either Oxford or Pfizer. In this study, they also compared the results to those seen in a large group of healthcare workers. and they observed a reduced response in patients with MPN at 58%, compared to 97% in age-matched healthy individuals, which was a significant difference as shown by the charts here. They also observed reduced response in patients taking ruxolitinib and hydroxycarbamide, although the numbers of patients in these groups was very small and requires further investigation. And finally, importantly, there was no observed difference between the response to the Oxford or Pfizer vaccines amongst their patient group. Next slide. So returning to our study from Guy's, we performed T-cell analysis using the same special flow cytometry technique in 20 patients after the Pfizer vaccine. In keeping with the results from our antibody analysis, we observed an overall T-cell response in 80% of patients. And we were also able to assess for the different types of T-cells, which was covered in the previous talk. So we looked at the presence of helper and the cytotoxic cells and observed that the response was predominantly in the helper T-cell subset at 75% positive compared to 35% in the cytotoxic cells, which is an important finding. And this is represented by the bar chart at the bottom right. The plots above show a strong T-cell response in a patient who would otherwise be considered to be immune suppressed in view of a diagnosis of myelofibrosis as well as ruxolitinib treatment. On the left are the unstimulated cells, and on the right we can see that upon re-exposure to the spike protein after vaccination, there's a significant reaction, particularly in the top left quadrant. So returning to our questions from the beginning, are MPN patients at increased risk from infection? From the data that we have currently, we would have to answer that they appear to be. However, the caveats remain that this was prior to vaccination and that there will be significant unintentional bias in the reporting. Secondly, do MPN patients respond adequately to vaccination? The answer from the data just evaluating a single dose would be that most patients appear to respond positively. However, we need to do more work to establish the response, particularly in at-risk groups that were highlighted by some of the studies. And finally, what level or degree of antibody or T-cell response provides protection in MPN patients? As yet, we don't have sufficient data to answer this question, and it will require ongoing combined work, combining laboratory data with data on incidence and severity of infection, as well as studying the impact of evolving COVID variants. So I'll now hand over to Jamie to discuss his important study on survey on the response to vaccination.
Very much, Patrick, and also congratulations and thank you for all the hard work you've done, running around, coordinating people, collecting all of those samples. I know it was an immense amount of work. So well done and thank you. So Jamie, you ready?
Hi.
You're muted. Yeah, great.
Am I now? Brilliant. Hi, so yeah, my name is Jamie. I'm one of the Hematology Physician Associates here at Guy's. I'm just going to talk you through a survey that we performed looking into the opinions and experiences of patients with MPN who underwent a vaccine for COVID-19. So a bit of a background, we basically wanted to collect obviously community opinions, so your opinions regarding COVID vaccination. And we wanted to focus on quite a large amount of patients. We were very, very thankful to MPN Voice for supporting that, and managed to get 960 individual responses who completed the survey from start to finish. And we basically focused at vaccine uptake, so how many people were having a vaccine, what were the reasons having a vaccine, why people might not want a vaccine, side effects relating to the vaccine, and how long they lasted for, and what the side effects were, how vaccines affected MPN symptom burden based on MPN 10 score. And then we wanted to understand people's worries and risks about having a vaccine. This was carried out in about March 2021, and we gave 21 days to complete the survey in total, and it was all done online. And essentially, we collected all the data anonymously, and then we present it now as one big group of 964 individuals. So if we look at who responded, the majority of people that responded to the survey were female. There was a predominant patient group of majority were ET, followed by PV. And then we had a pretty good split between less than 60 and over 60. So reasonably good sample. And if you look at what type of vaccine people had, roughly half and half had Pfizer, the other half had AstraZeneca. So that gives us quite a good data set to compare symptoms across the two different types of vaccines. So in total, 91%, 91.5% of people who responded actually had a COVID vaccine at the time, and almost everybody had only had one dose of their vaccine, and that was in line with the government's 12-week delayed second dose strategy. Around 8.5% had not received a COVID vaccine. 29 of those people were awaiting to have a vaccine but had not had one yet. But 53 people did tell us that they were not currently booked for a vaccination. 39 of those hadn't been offered one at all, and 14 had been offered and declined. And we hypothesized that we were aware of patients in our own hospital that told us that they weren't being told they were eligible for vaccine. And we were offered obviously guidance and support to point them towards the MPN Voice website, which stated that they should be prioritized for a vaccine. So we had, there was quite a low number of people who did not want to have a vaccine, and obviously wanted to explore that a bit more. In terms of people's preferences for a vaccine, the vast majority of people had no preference which vaccine they wanted to receive. They just wanted to get a vaccine, which was obviously reassuring. But bear in mind at this time, Pfizer was the most rolled out vaccine at the time. Other ones are still coming through. When we ask people about which vaccine they prefer and why they preferred a certain vaccine, people perceived that the Pfizer vaccine had greater efficacy and protection, a lesser side effect profile, but also it was more widely available information. And that's because in January, February, that was the predominant vaccine that we had access to. People who preferred to have the AstraZeneca vaccine were mainly concerned about the risks associated with reaction and anaphylaxis to the Pfizer vaccine. There was some data at the time potentially suggesting that an Oxford vaccine led to greater protection whilst waiting for your second dose, but also a predominant number of people wanted to have an AstraZeneca vaccine because they trusted it because it came from the United Kingdom. So we want to look at people's concerns as to what they're worried about with regards to COVID-19 vaccination. And a very small number of people actually said they had concerns about having a COVID-19 vaccine. So only 16.7% of people who answered said they were worried about having a vaccine. We then looked at those concerns, grouped them, and obviously people often gave more than one concern. So we grouped the different concerns together. There was obviously a very obvious recurrent theme about, is the vaccine going to work in patients with MPN? Patrick's already talked a bit about that just now, but does it respond? But that was one of the biggest concerns that we saw. People were often worried about how the vaccine may interfere with the underlying MPN, and there was a big focus, or a predominant focus, on the fact that the new vaccine had mRNA technology, and people were unfamiliar with what this meant and how this may interact with their disease. Could it progress or alter the disease? And that was their concern. And then there was always the people were concerned about the potential interaction with their MPN-directed therapies, so hydroxycarbamide or pegoruxolitinib, and would a vaccine interfere with those therapies and cause the MPN not to respond? There were obviously concerns about the long-term unknown risks of COVID-19 vaccine. And of course, one of the biggest concerns or emerging concerns at the time was of at that point, new emerging evidence that there was a potential risk of an increased risk of thrombotic events associated with COVID-19 vaccination. And that was very evident in people's concerns at the time. As part of the survey, we actually asked people, have you previously had a thrombotic event? So this is before COVID-19 or before the vaccination started. Have you ever had a thrombotic event? And you can see that the majority of patients, 76.9%, had never had a thrombotic event. And if they had, we asked them then, which type of thrombotic event have you had in the past? What was good for us is that all respondents who answered this question, in fact, 954 people reported no thrombotic event after COVID-19 vaccination. So it's 954 patients with a diagnosed MPN who responded, told us they did not have a thrombotic event after their COVID-19 vaccine, which for us was obviously really, really important news to take away. What we need to bear in mind is that there may be people who did not take part in the survey who have not had the opportunity to respond to this, but 954 people, of which none of them had a thrombotic event, is obviously very reassuring for us, because obviously that was quite a concerning thing for our patients and for us. In terms of side effects, a lot of people responded, 74 people said, and actually when we asked them how long their symptoms and side effects lasted for, the majority responded and had 0 symptoms up to 36 hours later, so all their symptoms are resolved. And essentially these were the known side effects we asked people about and said, did you have any of these symptoms? And you can see different categories, but predominantly more than 50%, almost everybody had symptoms that resolved within 36 hours. So we know that the side effect profile is quite good, and most people do feel a bit rubbish with fatigue and headache, it does resolve usually within a day and a half. We asked about MPN symptom burden using the MPN 10 score. So 16% of people in the survey answered this question and reported that they had an exacerbation or worsening of their already MPN 10 score. So we asked them to score themselves before the vaccine, after the vaccine, and then we showed that there was a change of +8 in the MPN 10 score. So significant enough to say there was a change in MPN symptom burden. And of all the symptoms that people described, fatigue seemed to show the largest increase in symptom burden across all 3 disease groups. And we focused on ET, PV, and MF. So fatigue seems to be the major one. So in summary, there was actually a very good favorable uptake. The majority of people in this survey wanted to have a vaccine and went and had a COVID-19 vaccine. The main concerns relate to obviously potential side effects and the undetermined efficacy in patients with MPN and how the vaccines would respond. When we looked at other vaccinations, the side effect profile in this survey was very similar to other vaccines and feared very tolerable. Like we said, within 36 hours, most people had responded, their symptoms had gone away. So very similar to other vaccines. We did find that there was statistical significance, so patients' MPN 10 scores did worse, and fatigue being the most common one. But we also need to realize that actually there is probably overlap between the MPN related and vaccine symptoms, and we can't say 100% it's just a vaccine symptom, particularly if it only lasted 36 hours. Were people answering the days after their vaccine, not in the weeks afterwards? That would be good for us to explore in the future. And obviously, the takeaway message, which is really important, is that no one in this survey reported a thrombotic event after their first COVID-19 vaccine, which is obviously very reassuring. Thank you very much.
Jamie, thank you very much. Jon, I think it's over to you to introduce the next speakers.
I will do, yes. Thank you, Claire. Thank you, guys. I thought that was a really, really excellent series of talks. So next up, we're going to learn more about the Mosaic study. Mosaic is a study which has been close to the heart of MPN Voice for a number of years. I won't bother saying anything more about it other than to introduce our speakers, who are Professor Lesley Anderson and Professor Mary Frances McMullin. Over to you, ladies.
Okay, so can you see my screen?
Starting to see it.
We're just about to see it, I think, Mary.
Oh.
There we go. Yep, there they are.
There we go.
Okay. And there we are. So my name is Mary Frances McMullen. I'm a haematologist in Queen's University, Belfast. And my colleague, Professor Lesley Anderson, who's now Chair of Health Data Science in the University of Aberdeen, is going to do the second half of this presentation. I think the best way we have decided is to do it all from the one slide deck. So I will keep changing the slides when I hand over to Lesley. So thank you very much for asking us to talk about Mosaic. This is myeloproliferative neoplasms, an in-depth case control study. And as always, great fun was arrived at in thinking up these names as we went. But this came along because when we start to think about the myeloproliferative neoplasms, the question arises, as it always does, what caused it? Why have I got this? What things have I done that could have contributed to this? And that is a huge issue for patients and for the doctors, but a very difficult question always to answer. Because when someone is diagnosed with a myeloproliferative neoplasm, they may be young, they may be old, but there's lots of things that happened in the past. There's obviously genetic factors. There's a huge question as what could have been involved. And this nice diagram of it as looking like a needle in a haystack, slightly cynical, but that really is the question. So some time ago, and it is quite some time ago now, Lesley and myself and Andrew Duncan from Southampton raised this question. We got together to think about this. And the first thing we did was actually look to see what actually has been done, what is in the literature, and what could we find from before. So Lesley is an epidemiologist, and she's very well trained in how to do this and how to look at the literature. And we started off a systematic review. Now, we started off with seeing what was out there, and there were 9,156 titles or abstracts that involved the issues that we were interested in. So we had to search through those and get down to the ones that were true studies which had looked at that. And perhaps thankfully, from our point of view, we ended up with 19 studies that we had to look at in detail and see what was actually in them and what had been done in the past. And looking at those studies in our systematic review, there were some things that stood out as being very important, or perhaps important, involved in the development of a myeloproliferative neoplasm. So family history, Jewish descent, certain autoimmune conditions and certain occupations came up. It's very important to note that 19 studies sounds quite a bit, but these were actually often very small studies with very little differences. But you can look at them a little further, which we did. And there's some evidence that certain occupations associated with certain myeloproliferative neoplasms. Commercial pressmen, poultry workers, petroleum refinery workers, funeral service workers appeared to have a higher incidence of PV, electrical device workers with ET, and other things like cooks, waiters, I'm not reading all that out, rural sector jobs, agricultural workers. Lots of things came up that maybe some of these groups had higher incidence of myeloproliferative neoplasms. But what does this mean? Because of course, is it the job or is it something that happens in the job? And certainly if you look at these, many of these occupations may be involved with certain chemicals or certain exposures to various things. Agricultural workers come up from that point of view, probably the funeral service workers as well. So we were very keen to look at this further, and we set up, therefore, the MOSAIC pilot study. Now, this was funded entirely by MPN Voice, and without them, this would not have happened. But it happened between 2012 and 2014. It recruited 106 MPN patients and 127 controls. And this was really very important because not only are we getting patients, but we were getting sort of age, sex matched controls. It was done in Belfast and Southampton for obvious reasons that we were at that stage, both in Belfast and Dr. Duncan was in Southampton. And it was mainly used to fund and recruit a PhD student, Glenn Titchmarsh, now James. And the point about this was that without this funding, the study wouldn't have happened. And Glenn worked very hard on it for a number of years. So did the rest of us as well. And the point of this study was not particularly to find out the cause of the MPN, which everybody would like to know, but really to test, compared to all the previous small studies, what were the methods that would work to actually do this, to recruit a number of MPN patients, to recruit controls, because that is really very important to do this. We also looked at what was the best way to get samples of the patients and to test all the information and surveys that we did. And it was extremely successful because despite the fact that I keep saying it's a pilot study, it is, of course, the biggest controlled study in MPN that has ever actually been done so far. All that previous work were much smaller studies. So from this, we published a number of papers looking at the results, which are very important. We had the systematic review, which we'd already done, and Lesley and I went on to work further and do further reviews on the epidemiologies and what we knew at that point. But we were also able to use the data from this study to look at the patient perspectives of a diagnosis of myeloproliferative neoplasms. That was quite interesting, what the patients actually thought their diagnosis was. We were collecting biological samples as well, and as part of the study, we were able to look at minor allele frequency of myeloproliferative neoplasms and compare that to an Irish blood donor population. However, perhaps more relevant to the patients, we did on all these patients' quality of life, and we were able to show that myeloproliferative neoplasms patients had a symptomatic burden and quality of life impairment. We did eventually end up with enough to publish a little bit on the actual possible causes, although that was not the main area, and I will have one more slide showing that in a little bit more detail. But we're also able to look at community-acquired infections and their associated with myeloid neoplasms. We looked at on the Mosaic study, the feasibility of the biological samples. That's what's the best way to collect DNA so that you end up with, when you finished your study, a very good group of DNA to study on both patients and controls. And finally, we looked again further at the quality of life compared to the patients and the controls. And that really resulted in that spider diagram that everybody likes, that shows that the patients had a much bigger symptomatic burden than their age-matched controls. So from the patient point of view, you're not just complaining you're tired like everybody else says. There's something actually going on there. So 9 papers from the pilot study is really quite impressive for a study of this type, and as I say, totally funded by MPN Voice. But however, we were actually sort of perhaps a bit more successful than we hoped we'd be, because we did actually have enough information to look at the factors from the study and see what might be associated with the MPNs. And the things that came out particularly were that JAK2 positive cases, in JAK2 positive cases only, smoking was a factor associated with the development of an MPN compared to the controls. In ET, obesity only, and frequency of CT scans came out as well. And of course, there are lots of factors in this because it's still a small study. Particularly if you look at the CT scans, well, is that because they had the disease, or was there something pre-morbid associated with the CT scans? And obviously there's a factor over time. So showed that we could do it, we showed the best methods, but it was extremely important to move ahead to a much bigger study. And that's what we are in process of doing at the moment. And I will hand over to Lesley, who's going to tell you where we are and where we are going forward. And I'll change the slides, Lesley, if you tell me to.
That's perfect. And thank you very much, Mary Frances, for a really clear overview of where we came from and where we're going. As Mary Frances has said, we conducted the pilot study to try and identify the best methods to recruit and also to collect information from patients like yourselves, and also from family members and friends. And so we're now embarking on a UK Ireland-wide study. We're recruiting across 19 sites in the UK, and we have confirmation that we will be opening a site in Cork. We also have 2 provisional sites in Limerick and Dublin, and those are subject to additional funding. Do you want to change the slide? Thank you. So I wanted just to highlight some of the Mosaic staff that are involved. I think some of them are on the call today, including Carolyn Gaston and Nufa Bethera. They are both working within the University of Aberdeen. And we have a new appointment coming in place in Aberdeen on the 13th of September. And Evelina will be joining us as a research assistant, and her funding is being provided by MPN Voice. We also have a PhD student who is starting, and this is to get their doctorate in research looking at myeloproliferative neoplasms, and Emma will be joining us at the end of September. We also have a lead in Belfast since I left within the last year to move to the University of Aberdeen in Scotland, and Dr. Charlene McShane is leading efforts from the research side in Belfast, along with Therese Kearney, who is a research fellow and funded by the Leukemia and Lymphoma Northern Ireland funding. We also have, if you want to click the slide there, we also have a large steering group by which we have our key players involved, which is Charlene McShane, Mary Francis and myself, along with Dr. Andrew Duncombe, who we highlighted was based in the University of Southampton, and the idea came for the Mosaic study from Andrew many years ago, about 13 years ago, whenever I arrived back in the UK from working at the National Cancer Institute in the United States. We also have a colleague, Frank de Vogt, who works at the University of Bristol, and also Professor Lynn Fritschi from Curtin University in Australia, both of whom have experience in occupational research. And as Mary Francis has highlighted in the pilot study, we were particularly interested in looking at potential causes, not just the types of jobs that might be linked with development of MPNs, but also the exposures that might lead to that. I'm sure many of you have heard from Dr. Ruben Mesa in the US, who developed the MPN SAF questionnaire. And I'm sure many of you have completed that if you've been involved in clinical trials and even just in your standard clinical visits. And that really measures the symptom burden of patients. And we have two patient representatives who are very involved in our meetings and in the decisions and having a voice for patients more broadly as part of the research. And David Campbell and Megan Laird have been instrumental in getting things together so that we could start the Mosaic study. Slide. So some of you might be wondering, oh, this is a really interesting study. I'd love to take part, and we would love to have you. If you're invited by your healthcare professional, we are recruiting about 650 MPN patients across the UK and Ireland. And as Mary Francis had said before, our pilot study of 106 patients was the largest study to date. So this study will be large enough for us to really be able to identify those key factors that lead to the development of myeloproliferative neoplasms. We are requiring specific confirmed diagnosis of MPNs, and there are criteria that the healthcare professional team will have so that they can identify whether you meet those criteria to participate. And we're requiring that only people diagnosed in the last 2 years take part. And there's a real reason from a methods perspective to do that. If you've had your disease for a long time, you might have changed your lifestyle. You might have made modifications, you might have changed your diet, you might have changed your physical activity. And that, therefore, it's much harder to recall back to before you were diagnosed with disease. And that's the period that we're particularly interested in looking at in the Mosaic study. We're only recruiting adults into the study for the purposes of the research, and informed consent needs to be provided. All participants will also be taking part in a telephone interview, and so they need to be able to communicate effectively to be able to answer questions from the research team. And so while we would love everyone to be involved in research, we would ask that you wait until your healthcare professional team invite you to participate. And if not, we will be doing surveys through MPN Voice in the coming years. And we'd really ask you to participate in those because they help to shape the research as we're moving forward. We're wanting to evaluate lifestyle factors and medical risk factors, as well as occupation. And we have quite an intensive occupational calendar that participants will fill in, so the types of jobs that they have done over their lifetime. And then there are bespoke questions for each individual who takes part about the jobs that they have done And that helps to identify potential exposures to known carcinogens or factors that can lead to the development of cancer. We're also looking at genetic causes, and we're collecting DNA and another factor called RNA from blood and also from saliva. And we're also collecting something which is always a very interesting question, which is around toenails. If you have participated or if you get asked to participate in the future, you might be wondering why we want your toenails. These provide a really good resource for us to identify factors and exposure to environmental factors, because it takes about a year for your big toenail to grow from the root to the tip. And so it gives us an indication of exposures that you were exposed to about a year previous. And as Mary Frances said, in the pilot study, we were able to look at quality of life, and the spider diagram, or the radar plot, which it's termed, that you can see on the screen shows that patients with MPNs, who are highlighted in red, had much higher symptom burden than controls. And as Mary Frances had said, you know, many people feel tired and fatigued, but MPN patients have a much higher burden of fatigue than the general population. Next slide. As Jon said earlier in the presentations, many surveys have been undertaken through MPN Voice, and one of the surveys that we had asked members of MPN Voice community to do was in 2019, and that was to look at potential factors that patients felt might have led to the development of their disease. We had 200 many different potential ideas and thoughts around factors that might lead to disease. But one of the main things that was identified was stress and major events that had occurred within individuals' lifetimes that may have triggered the development of disease. This wasn't something as researchers we had thought about or we were going to include as part of the research. And based on the input from patients, we were able to increase our questions and really tailor those to the factors that patients feel might be important. Next slide. As stated previously, we're collecting samples. We're going to be collecting over 5,000 samples as part of this study. Those who take part will provide 2 samples of DNA and 1 of RNA from a blood sample. And patients will be able to go just to their routine, their normal routine blood appointment to get their bloods taken. Controls will go to either one of the hospitals that are participating in the study or to their GP to have bloods taken. And we're also collecting some information on vitamin D status in some sites, not in all. And the saliva and toenails are going to be at-home collections. Then there's diagrams that show patients how to complete those samples so that they can provide them to us in a stamped addressed envelope. So without funding from MPN Voice, none of this research would have happened, and we've been really thankful for the investment, not only of the charity itself, but of all of you as members of the charity and in your fundraising efforts. There have been very many people who have done walks, done hikes and climbed buildings and to raise funds for the Mosaic Study and for MPN Voice more broadly. And that is fundamentally important, because without that, we wouldn't be able to do this research. That's also led us to be able to obtain funding from Leukemia and Lymphoma NI and from Friends of Anchor, which is the charity based in Aberdeen. And when I moved, they were able to provide funding so that we can have a site opened in NHS Grampian in the northeast of Scotland. This means that we have a really good geographic representation of the study across the UK. And there are referral our possibilities of referral into hospitals so that patients who are interested and eligible to participate can take part in the research. The University of Aberdeen and Queen's University have also been fundamental in providing funding and supporting the research as we're going forward. And we've been doing Just Giving fundraising efforts, which included the Santa Run in Belfast and different charitable events. We are looking to raise additional funds, and this is to support additional factors of research so that we can look at geographical influences on disease, as well as assessing the quality of life burden. So if you have any available funds and are able to support the research, we would be really grateful for that. What I would say is we've had a number of delays as a result of the COVID pandemic. We were ready to start in March 2020, just as the pandemic hit, and with hospitals closing to new clinical trials and new trials opening, we have had many delays. We opened briefly in December before the second wave, and we're now at a point where we're hoping to open sites within the next couple of weeks. Please be patient with us over the coming months. The opening of sites are highly dependent on staff availability, the current situation with the pandemic, and the resources that are available for the research and clinical staff involved in the project. We will leave this with any questions and answers which can be addressed at the open session. And I'd just like to thank everyone for their support of the research so far. And we're really excited to be at this really crucial point moving forward with the project. The ambition is to have recruitment complete by the end of 2023. And at the beginning of 2024, we should be coming out with some of the key findings from the research. Thanks, John.
That's fantastic. Thank you very much, Mary Frances and Lesley. Very informative and obviously very important topic for MPN Voice members. We've been, as I say, we've been involved in the project for a long time now, and we're very, very happy to support you on an ongoing basis. So I'm conscious that we're running a little bit late, probably mostly due to me, but so without further ado, let me introduce our next speaker. This is Claire Woodley. I know Claire quite well myself. I see her when I go to Guy's every few months. So it's really, really nice to see you in the panel today, Claire. Over to you. Great, we can see your slides.
Good afternoon, everyone. For this talk, we're going to look at why it's important to track your symptoms and how you can do this. We'll look briefly at what we know about symptoms before moving on to why we should track symptoms and how to do it. I wonder how many of you have come across this scenario when you've been into your clinic appointments, where the clinician has told you it's good news, your blood tests are just where we want them, and you're sitting there thinking, well, why don't I feel that well? Well, hopefully when we explore the symptoms, it may give you some keys and things that you can go into your consults with. So MPNs can be associated with a substantial disease burden, with symptoms negatively impacting on quality of life for many patients. Symptoms may include fatigue, pruritus, night sweats, microvascular symptoms, splenomegaly and its associated symptoms such as abdominal discomfort and weight loss, anxiety and worry. The US MPN Landmark Survey was the first large observational study to evaluate the impact of MPNs and symptoms as reported by patients on their health and productivity. And they found that there was a reduction in quality of life and working productivity. Studies suggested that experience can differ between countries. So to see how patients outside of the USA were affected, the global landmark study was completed. It surveyed both patients and physicians in 6 countries, including the UK. Some of you may have participated in this online survey. It covered areas including physician and patient relationship, attitudes towards disease and treatment and drug use, the burden of the disease characteristics and demographics. The study showed that most patients had experienced symptoms over the previous 12 months related to their MPN. In general, women reported overall higher levels of symptom burden, and the majority of the patients experienced a reduction in their quality of life, which was not only related to the symptoms, as it found patients with a low symptom burden reported a reduction in quality of life. This slide, whilst a little bit small, shows the top 10 symptoms that patients reported over the previous 12 months. It's split into the specific diseases, so covers ET, PV and MF. What you can see and what we've heard already today is that fatigue and tiredness was the most reported symptom. It also covered other symptoms that we know about, such as abdominal discomfort, pruritus, loss of concentration, headaches, and some other symptoms that perhaps might be a little surprising, such as difficulty in sleeping, bruising, weakness. The study also noted that the emotional burden of MPN with patients experiencing anxiety, worry, and frustration. And this was not only impacted on the patient, but on their relationships, their families, and their social life. It also saw that there was a financial burden with living with an MPN that impacted on patients. And this was sometimes for patients who had a reduced ability to work, or they had to change their working hours or retire early. So having heard a little bit about some of the symptoms patients reported, why should we track our symptoms? I often use this picture of the iceberg when talking about symptoms, because to me, it reminds me that actually what we see is not always the true picture of what's going on. And I think this is sometimes the case when patients come into their clinic consults, and especially relates to symptoms. So as a clinician, I'm sure my colleagues would agree, it's essential for us to know what symptoms our patients are experiencing, how they are affecting you, and what is the impact of your symptoms or MPN on your lifestyle, quality of life, family, and friends. Tracking your symptoms will enable you and your clinical team to see if they are changing over time. Are they improving or getting worse? Are there different symptoms occurring? It can identify if symptoms are responding with treatments or is change in management needed. For example, if somebody has experienced pruritus or itching, is it getting worse? Do they need an antihistamine to help? Or is their current antihistamine not working? It may also prompt discussions about non-pharmacological ways of managing some of these symptoms. For some patients, it can help with having a more informed conversation with your healthcare team. For you, it can identify issues that may warrant further discussions and support in your consults. As a patient, tracking symptoms gives you an active role in managing your symptoms, condition, and care. Through tracking symptoms and sharing these with your clinical teams, there may be additional supports and services that can be accessed to help you manage them. For example, somebody reporting fatigue may be referred to a physio or to an OT team who can help with ways of managing the symptoms. A psychology team may help with adapting to your condition or living with your MPN. Dietitians, there are community services that can be accessed, and also help with financial support if this is an impact on you. So how do we track symptoms? Using symptom trackers or diaries can offer valuable insight into symptoms and can assist with making more informed decisions about conditions and treatments. There are MPN-specific resources that are available to assess symptoms. The MPN-10 is a validated tool for assessing patient symptoms. It's a simplified version from earlier tools and covers 10 clinically relevant symptoms. These are, which are a little bit small to see on the actual scoring form, fatigue, filling up quickly or early satiety, abdominal discomfort, inactivity, problems with concentration, night sweats, itching, bone pain, fever, and unintentional weight loss for the last 6 months. Symptoms are rated 0 to 10. 0 means no, the symptom is absent, to 10 being the worst imaginable. There is no preset score, and I encourage patients to give the score that they feel most reflects their experience of the symptom. And then over time and on subsequent monitoring of the symptoms, we are able to see how the symptom changes. A total score out of 100 is calculated. It allows us to see which symptoms are experienced for each patient, but also I find it's helpful to discuss and explain to patients how their symptoms may develop and kind of teach and educate patients on how they may manage these symptoms. I encourage patients to complete between their clinic appointments. How often you complete probably depends on your individual case. For some patients who may have just commenced a new treatment, we may ask them to complete weekly so that we can see how the treatment is impacting on their symptoms. Others, it may be just ahead of your appointment time. I do have some patients who then email me their MPN scores, and in doing this, it means that as their clinical team, we can review their symptoms ahead of their appointments. There is also an online version of the MPN 10 tracker, which can be found at this website. So the previous MPN 10 talks about 10 symptoms, but it is important to remember that not all symptoms or the impact of the MPN are measurable on the assessment form. You may find it easier to complete a diary and document other symptoms or anxieties or worries or concerns that you maybe have that can be discussed with your clinical team in your consults. However you choose to monitor symptoms, get into the habit of regularly tracking them. But remember, it is also important to share them with your clinical team. We would also like to hear from you as patients how you feel the best way to monitor your symptoms may be and how you may interact with your clinical team in informing them about the symptoms. For example, it could be a phone app that you and your clinical team can access, or you may find that the tools that are already in use are good enough for you to monitor them. Through monitoring symptoms and the impact of your MPN is having on you, you and your clinical team can work in partnership to help reduce the burden of living with an MPN. Thank you.
Thank you very much. Amazing, lovely. Really helpful. And maybe we'll get Danny to sometime put in the chat the link for the tracker, or maybe Claire, you could put that link in the chat. Yeah, that'd be great. I can see questions coming in the chat, so please do keep them coming. Now it's my great honour and privilege to introduce to you someone who's been a colleague of mine for, oh golly, how many years, Alessandro? I can't remember now. Long time. And we're really, really grateful that Professor Vannucchi is joining us. Now, that can't be the view from your office. But he lives and works in the very beautiful Florence. We've worked together for a long time. And I'm so happy that he very kindly agreed to join us this evening to give us a historical perspective on MPN. So welcome, Alessandro, and thank you very much.
Thank you, Claire. Thank you for inviting me. It's really a pleasure to be here. And thanks to the organizers. So I know that we are a little bit late, so I will not spend...
Plenty of time. We've got plenty of time. Please don't worry.
Okay. So yeah. I hope you are seeing my slides.
Yes.
Okay. So thanks for inviting me to make this. That is a quite unusual presentation for our meetings, because we are used to present and discuss data. This is something that is usually reserved to old people. And so I'm wondering whether you are thinking that I'm an old person in the field of MPN or not. That said, but this is very friendly from my side, I think that going back to review the history of MPNs is really important. And I will start with this famous statement by Thucydides, who was a famous historian from ancient Greek. You must know your past history to understand current times and direct the future. And this is true not only for our daily life, no, it's not true only for our politicians that should remember this more often, but also for us clinicians and for biologists. So if we go back quite far in the history, the discovery of these disorders happened around the end of the 19th century, myelofibrosis 1879, followed by polycythemia vera, and it was around 1930 that essential thrombocythemia was described by Epstein. But the birthday for the modern MPNs is fixed at 1951, when William Dameshek, who has been a famous hematologist from the United States and also wrote a lot of papers on this field, wrote an editorial that was entitled "Some Speculations on the Myeloproliferative Syndromes." And he put together, and that at that time was really a new idea, put together these three disorders. At that time, he also included chronic myelogenous leukemia in a unique family of disorders. And he thought, and he wrote, that these disorders, even if appearing quite different each from the other, they were in some way unified by a common mechanism that, of course, at that time was totally unknown. And now we know that it's largely due to the mutations in the JAK2 gene and the JAK2 path. So this was the beginning of the modern history of MPNs. But to go ahead in the development of the knowledge in these disorders, I think that one main point has been the ability of physician, biologist, nurse, and I'd say all the scientific community of MPNs to develop a common language. You can call the same thing into different ways, but what is important is that if I say patata, that is how I called it in Italian, it's exactly the same kind of food as Claire that called it potato. What does this mean for the MPNs? This means that the community of clinicians and science was able to develop a common language for considering, making diagnosis and managing these disorders. And this led indeed to the development of diagnostic criteria for assessing the response of the patients to treatment, or for finding those patients most suitable to receive a stem cell transplantation, that has been shared by all the clinicians involved in the management of MPNs. So we have a number of criteria that are used the same in the different parts of the world. And indeed, these criteria were often translated into something that for us is like a law. These are guidelines from the WHO, from the NCCN, from the European Leukemia Net, and of course for local societies such as the British Society for Hematology Guidelines. And all these tools are used every day in our approach to the patients. And so we can be confident that what I called myelofibrosis, in Italian mielofibrosi, is the same myelofibrosis as Claire can diagnose in London. So I will touch very briefly some of the main achievements in these regards. And of course, the first in terms of diagnosis is the development of diagnostic criteria that were mainly guided by and led by the WHO, by the World Health Organization. They clearly succeeded during years after the first criteria that were developed by a collaborative group of clinicians, the polycythemia vera study group around 1980. And now we have the 2016 WHO criteria that allowed to use well-defined criteria for making diagnosis, the same diagnosis to any patient in the world. And what is really important in this regard is that there has been a will drive in the development of these criteria, and this has been represented by the discovery of the first genetic mutations that are associated with these disorders, and their strong association with these disorders led them to be incorporated as main diagnostic criteria in the WHO classification. So we know that patients may have the JAK2 V617F mutation, and this is the most commonly represented, and it covers more than 95% of patients with polycythemia and about 60% of patients with ET and MF. And then it was followed by description of the JAK2 exon 12 mutation in about 2 to 3% of patients with polycythemia vera. And no need to say that the colleagues from UK had a pivotal role in the description on these and other mutations. Then we had the mutations in MPL, that is the gene encoding for the receptor of thrombopoietin, that is an hormone stimulating the production of platelets. And this is associated only with ET and myelofibrosis and not with polycythemia vera. And more recently, description of a third gene mutated recurrent in these disorders, that is calreticulin. And again, this is shown only by patients with ET and myelofibrosis. So these are what we call these driver mutations of MPNs, because we know they are strictly associated with and are the responsible for the development of these disorders, and they are main diagnostic criteria. And they are currently evaluated in any patient who is suspected to have an MPN. But in addition to the relevance for making diagnosis of MPNs, the discovery of the JAK2, MPL, and calreticulin mutation point to a main culprit in the pathogenesis of MPNs, and this is the JAK-STAT signaling. JAKs are in proteins that are associated with the receptors for many growth factors, many cytokines that promote the production of red blood cells that are abnormally increased in polycythemia vera, or platelets that are abnormally increased in essential thrombocythemia, and promote the development of fibrosis in myelofibrosis. But also this STAT also is associated, JAK and STAT are associated also with the inflammatory responses. So they are involved in the response of cells to what we call as inflammatory cytokines that are considered right now the main responsible for the symptoms that patients develop beyond contributing to the pathogenesis of MPNs. And it's important to stress that even if the JAK2 mutation are clearly associated with these proteins, also the other two mutations, MPL and calreticulin mutations, however, they abnormally activate the JAK-STAT signaling. And so there is a unifying theory that has been discovered just starting from 2005, when the JAK2 V617F mutation was discovered, that is pointing to abnormal activation of this single signaling pathway in the cells. And this led to a therapeutically relevant discovery that was the discovery of JAK inhibitors, that now are drugs that we can use for the treatment of these disorders. And I have to say that it was quite surprising that after having discovered these mutations, that for us were enough to understand, making diagnosis, and also treating these disorders, as I have discussed just now, then it was quite surprising to learn that MPNs are very complex diseases in terms of genetics, because patients with MPNs do not have only JAK2, but have a number of other mutated genes, what we can call collectively as myeloid neoplasm associated genes, because they are not specific for MPNs, but you can find them in acute leukemia, myelodysplastic syndromes. And so these are genes that are mutated in a larger group of diseases, myeloid diseases, as compared to only MPNs. So these discoveries have been very important, not in terms of diagnosis, because they are not specific, but in terms of learning how these mutated genes may be associated with different prognostic outcomes of selected categories of patients. but also because they pointed to other abnormally regulated signaling and pathways in the cells. And so they led us to realize that beyond targeting the JAK-STAT signaling pathway, there might be several different target points for new drugs. And this is, on your right, is a very incomplete list of new targets for new drugs that are undergoing experimentation. So clearly we come from a very exciting 15 years from 2005, where accumulating discoveries in mutation in terms of genetics of these disorders has totally changed our way to approach the diagnosis, but especially to treat patients. But I think that these discoveries also pointed to another very important point for the patients and for the clinicians. And this is the promoting us as clinicians, I mean, to realize that the complexity of an MPN patient was much greater than we initially believed. And to this, there has been a number of variables that contributed, not only the awareness by physicians, but I'd say especially the role that patients acquired in the last years, and you, of course, are an examples, the development of support groups for patients, and in some way also the involvement of companies that became interested in the development, in developing drugs, in performing trials for these disorders that before were indeed poor of clinical trials and were considered poor disorders, not a good field where to invest from the companies. And the best way to underline how this moved from genetics to the patient is what has been just discussed by Claire Woodley about the relevance, the importance that we are now paying to the symptoms of the patients, and the fact that patients have become active actors in this. Not only the physician asking, how do you feel this, do you feel that? But the patient that comes to us is well aware of his symptoms, her symptoms, and takes to the visits, for example, the MPN score or a diary as suggested. And last but not least, all these discoveries have moved the field towards the concept of personalized medicine. So we are moving from considering all patients with polycythemia vera, all patients with myelofibrosis, and so on, as having just one disorder, but we are realizing that there are differences in the different categories of MPNs and differences in a unique category of MPNs. And this is important in terms of complications that are associated with the disease, but especially, and I mean especially for patients with myelofibrosis in terms of survival. And this led to a number of efforts, I'd say great efforts, in developing over the last years progressively better risk scores for stratifying patients according to their main risks that are largely thromboembolic or hemorrhagic risks for patients with polycythemia vera and essential thrombocythemia. And we have two risk models that we use to stratify patients. And this was really important for patients with myelofibrosis because these patients have significantly shortened the survival. We know that stem cell transplantation is an option, but it is a risky option. And so it's important to be able to identify at best the patients who are more at risk and who are more appropriate to be addressed to stem cell transplantation. This is a number of scores that have been developed over the last years, and it's important that also the NCCN guidelines, the latest one, have incorporated all these scores in order to help and facilitate the physician to take decisions. And the last few slides are just to make some kind of historical notes about the main achievements in terms of treatment. And what I think is really a good point for us physicians is what has been made by investigators. you probably know that it's really difficult to start clinical trials because it's really expensive. There's a lot of laws that regulate these clinical trials. So it's really a huge affair. But there have been historical trials that have been initiated, led, and guided by investigators. These, for example, in patients with polycythemia vera, led to point to aspirin as a key drug in reducing the risk of thrombosis, and more recently, in identified what we think is the best hematocrit target to be maintained in the patients to reduce the risk again of thrombosis. And in essential thrombocythemia, there have been one of the first clinical trials in essential thrombocythemia that established the relevance of hydroxyurea for treating patients at high risk. And Claire Harrington was the principal investigator of the PT1 trial that established the superiority of hydroxyurea over anagrelite plus aspirin, both in terms of prevention of arterial thrombosis. Of course, not all is only on the shoulders of investigators. We have to acknowledge that companies, as I mentioned before, have been involved in the development of new drugs. And most of you, of course, know the results of the trials that have been performed in patients with myelofibrosis with the JAK1 and JAK2 inhibitor ruxolitinib, the COMFORT-1 trial that was an American and Australian trial, and the COMFORT-2 that was an European trial, again led by Claire Harrington. And this, of course, established the relevance, the importance of ruxolitinib for managing patients with myelofibrosis, and this is an approved drug. Also, for polycythemia vera, ruxolitinib has been approved on the basis of 2 clinical trials, the RESPONSE and the RESPONSE-2, and the drug is now available for patients who have polycythemia vera that is resistant or refractory to the treatment with hydroxyurea. And interferon, going back to the history, the first use of interferon goes really back. But now we have evidence from more recent trials that interferon may be really an important drug for patients with polycythemia vera, and the drug has been approved very recently by the EMA for selected categories of patients with polycythemia vera. And also, and this is my last slide, we are starting to move anymore in the field of personalized medicine, and we are starting to try to change some hard stones in the management of these patients. So we are going back to patients considered until now at low risk with PV and essential thrombocythemia, and ask if what we are doing currently is enough or we can improve. And so there are trials for patients with low risk polycythemia vera, and an important trial from the PT1 study in patients with intermediate essential thrombocythemia that established a very important, I'd say, criterion and gave a very important response. We are doing pretty well right now in patients with intermediate risk AT because they do not deserve treatment. So clearly, this is the results of a number of people, and this is an incomplete list of colleagues and friends who have contributed over the last years to these achievements. This is my group in Florence that I'd like to thank for being with me since many, many years and work with extreme enthusiasm. But I'd like to thank especially the patients who have been so trusting and dedicated to the field and to us physicians. This is a picture from a patient day that we lead in Florence. Unfortunately, it's 3 years ago because then we have to stop because of COVID pandemic, but we hope to be again live. Thank you for your attention.
Many, many thanks, Professor Vannucchi. What a lovely slide to finish on. I couldn't agree more. It'll be great to see MPN patients back in the same room, exchanging their stories and hearing from doctors like yourself. Fantastic talk. Thank you very much indeed.
Thank you.
Okay, so now we hand over to our patient talk. So I'm really pleased to introduce Maz Campbell-Drew, who I'm sure many of you know in some form or another, probably from Health Unlocked or something like that. If you haven't met Maz before, she's a wonderful person. I've known her for many years now, and she'll be ably supported by Mark Taylor, who's recently joined us as a volunteer, helping us with social media. So over to you, Maz.
Thank you very much, John. I've gone completely bright red now, but that was very kind of you. So I'm sorry I'm glowing. Hello, everybody. It's really nice to be here and to be able to talk to you all. As John said, some of you probably do know me from Health Unlocked or from our previous forums or patient days or emailing me or phoning me. I get lots of people phoning me as well. I am the administrator for MPN Voice, and also, I have got ET myself. Some of you may not know that, but yes, I do have ET. So I'm just going to talk a little bit about that. I was diagnosed back in 2003, and I was told then that it was a disorder because they were disorders then. When I was told that I had ET, I was just very confused and very, very frightened. I'd never heard of it. In fact, not many people had. And I worked for GPs at the time when I was living down in Sussex. I live in Devon now, but they didn't know very much about it either, and they were just more concerned that I could still make their coffee and, you know, do the work I was supposed to be doing as the office manager. So there was a lot of sympathy there from them, which was typical, bless them. So I tried to find out as much as I could, and that was really, really difficult because there wasn't much about, not much information anywhere. And my hematologist, who was absolutely lovely, he could just tell me that actually I was going to lead a fairly normal life and I would be okay as long as I promised him I would take my little aspirin every single day. And that he did say that sometime in the future I might have to start taking hydroxycarbamide, but he wasn't very keen on doing that because he said I was a bit young. I was 44, so being told I was young for something at that age was actually quite nice. So I did find out what I could, and that I was at risk from blood clots and strokes because of my sticky blood. And I thought, well, so are a lot of other people. And I've never smoked, and I drink very little alcohol. I probably have the occasional sherry at Christmas because otherwise I'll fall off chairs, etc. So straight away, I had eliminated a lot of my risk factors, but I am a chocoholic, and that means actually I'm not the ideal weight for my 5'2" frame. But do you know what? Can't be perfect all the time, because that would be really boring. So how was ET going to affect my life? Well, for over a year before my diagnosis, I had been suffering very badly with constant dizzy spells, head pains, lethargy. It was just awful. My head was all over the place. And my GP kept telling me that it was hay fever. If only it had been hay fever, I wouldn't have minded that so much. But my hematologist did think that those symptoms were part of my ET. Right back then, he did say that that's, you know, was all part of it. And that he thought perhaps hydroxy might help, but sometime in the future. And he just wanted me to see if I could try and cope and live with those symptoms. So I said to myself, do you know what, Maz? You've got all your faculties, you can walk, you can talk quite a lot, and you can see and hear, and you can do everything for yourself. And there are a lot of people out there that can't. So I found ways of coping with those symptoms. And it was a struggle some days to do that. I had quite a pressurized job, and so I just had to be extra careful, checking things twice, sometimes 3 times, to make sure I'd done them right. And if I was very, very fatigued or confused, I would just stop and make myself a cup of tea and just sort of have 10 minutes out. You know, and if I couldn't go to work, I couldn't go to work, and I would just have a little sleep, go home and then go back. And I kind of got used to living with the dizzy spells and the confusion. I found ways of coping with it, just try to put them in the back of my mind. And they did become part of my life over the next couple of years. They were sort of constant. But then there were times when I was out without them, and it was fantastic. So my haematologist was actually right. I was leading a fairly normal life. So that was okay. But about 13 years ago, it all sort of started getting worse again. And I found I had to have time off work. So that's when I was started on hydroxycarbamide, because it was just really affecting my life. I couldn't also explain to people and make them understand what the fatigue is like, that it's beyond tired. It's not just being tired, it's your whole body. And that to try and go upstairs, you almost have to lift one leg up at a time to get up the stairs. It's like your bones made of lead. And I got very, very despondent, and that is not like me. I mean, my mum said that when I was born, I came out laughing. So for me, getting despondent and fed up with things is just not me. And so I wanted my ET to go home or go anywhere. I didn't want it. So my haematologist did start me on the hydroxy. And actually, I was really worried about that, because it was the very word chemotherapy. And it just scared the daylights out of me. It really freaked me. Would my teeth drop out? Would my hair drop out? Would this, would that, all sorts of things? Would I glow in the dark when I took them? And I had so many of those questions, but so few answers. But I did begin to feel a lot better on them. And, you know, I do still take them, and I do still get some dizzy spells. I still get fatigue. I still get bone pain, but it isn't now as often. And I do try and cope with them. And I've got a little dog that you probably just heard barking. Sorry about that. So I have to take him out for 3 walks a day. And that really does help. So gentle exercise, if you can do some form of exercise, really, trust me, it does help with the fatigue. So do try it. But I still needed some answers to all of those questions that were whirling around in my head. And the only information I got from my next haematologist, I'd moved from my other one, was a leaflet about leukemia. I haven't got leukemia, so it did me no good whatsoever. So I started to look on the internet, as you do, and I found this organisation called Mpd Support, which is what we used to be called, and they were based at Guy's and St Thomas's Hospital in London. And I thought, well, they're very respected hospitals, so I'll have a look at what they're saying. And I did like what I saw, and I thought, well, I'll sign up to receive their newsletter. And it did say, if there's any way that you can help, please let us know. So I did that, and I will just share my screen. Oh, sorry, hang on a minute, I've pressed the wrong button. Oops, sorry, I've got to share screen. Hang on a minute, I have lost it. Sorry about this, people. Just shows that I am live and not recorded. They said, yes, okay, will you help us? And that was from Claire and Anne-Marie, that's no longer with us. She's now in America. And they said, can you do some admin for us? And that is how I became the administrator for MPN Voice. And what is my role as administrator? Well, I deal with all inquiries that come through and registrations. So I will send you the welcome email and letter. I will answer your inquiries, talk to you on the phone. I help to maintain the website, and I facilitate the regional patients forums with my colleague Nona, who's not here today with us. The buddy support program, so I put people in touch with buddies. I match them up with a buddy so that they could get help and support for their MPN. Social media, I do some of the social media, and Mark will be talking to you in a moment. He's now taking over a lot of that. And our online forum at Health Unlocked, so that's probably where a lot of you know me from. I deal with all the posts on there, so I'll come in and answer them and get information from the medical team, and put replies on there and sort problems out. And so I'm sure there are many of you here today that are part of that community. And it's fantastic. We started that in 2012, and it is just for people who are affected by the MPNs. So it's patients, family members, carers, and healthcare professionals. And it's where we can share our MPN experience with each other and receive insights from people in the same situation. And that is very important so that we can give support and encouragement as we share our knowledge about all aspects of living with an MPN, because you know, if you've got an MPN, it's so powerful that you can pass on your knowledge to other people, and it really does help other people. We've currently got, which I think is amazing, 7,379 members who are based across the world. So it's a fantastic community that are all chatting with each other. And our role, the MPN Voice role, as administrators of that, we moderate the community so that we are ensuring that each question, post and replies are relevant, informative, supportive, non-confrontational and accurate. And we're very fortunate because we've got the support of many healthcare professionals who advise and support us and answer many of the questions. And there are little niggles of now and again, as many of the members will know, that I have to jump in and try and sort out, but it doesn't happen very often. On the whole, it is a very lovely, welcoming, supportive community. So if you're not part of Health Unlocked community, please come and have a look. And during the COVID crisis, the Health Unlocked Forum has been an absolutely vital resource for MPN patients, the family members and healthcare professionals to access the information that we've been able to give out and provide support to each other. We've needed it, you know, emotional and well-being support, because it's been such a difficult time for all of us and we've all needed it. And you know, it's helped me an awful lot as well to be communicating with all of you on there. So thank you to all of you, because you've given me so much support as well through it all, and you're all amazing. So what else do I do? Well, I'm involved with the fundraising team and fundraisers, and these are some of our amazing fundraisers from last year who did some amazing events during the pandemic, the lockdown, when they couldn't get out and do the normal fundraising events that we would have had in the community and wider events. So these lovely people here did all these events at home and in their local areas. We had hula hoop dancing in different costumes. We had Eleanor here, she climbed up Ben Nevis going up and down the stairs. We've had people cycling, including Jon there. Sorry, Jon, I've put in a little photo of you there. And other amazing things. And these people are wonderful. And these fundraising efforts from all of you, as we've said, you know, they support all these amazing research projects that we have. The Mosaic, Lesley spoke about the funding, and Mary Frances did. So we do need the fundraising and the fundraisers to support us so that we can keep going to support these vital projects for all of us. And you know, it's important to me because I've got ET and I want to know why I've got it, and I want to find a cure for it. So that's our call to all of you, that you know, please keep supporting us. And the fundraising team, we've got an amazing fundraising team of regional fundraising organisers that are based around the country, that are supporting our fundraisers, and you know, they're an amazing bunch of ladies that are helping myself and Marilyn, and they're supporting our fundraisers throughout the year. And our fundraising team, the MPN Voice fundraising team, we work very closely with the Guy's and St Thomas's fundraising team, and they are vital to us because they give us lots of help and support, but also they secure places in some amazing events, iconic events for MPN Voice fundraisers, like the London Marathon and the St Thomas's Abseil, which I know a lot of people have signed up to this year. Hopefully some of you are listening here today. And that's taking place in September, which is Blood Cancer Awareness Month, the whole month. And Thursday, the 9th of September, is the International MPN Awareness Day. So we're quite excited that the abseil is taking place sort of just the day after and on the Saturday. So good luck to everybody who, who are doing events during September. There's lots of other events going on, not just people doing the abseil. There are people climbing up Snowdon and Penny Van, and people that are doing lots of other little events that are, they're pooling all the money together. So just like to say good luck and thank you so much to all of our fundraisers, past, present and future, because your support just means so much to all of us. It really, really does. And Marilyn, myself and the rest of the team on the fundraising team, we just think you're all absolutely amazing and we're in awe of all of you. So thank you so much. But we want to do it together and we want to find the cure. So please do keep on. Sorry, I get very enthusiastic about fundraising, as you can probably tell. So the fundraising team have now started some more social media with the help of Mark, who's talking after me. And we've expanded onto Facebook. We've now got a dedicated Facebook group for fundraisers, so that all of our lovely fundraisers can come on there, support each other and share their photos and tell us what you're doing. The same on our Instagram page. We want you to come on there, tag us, tell us what you're doing, put your photos on. We want to hear all about it and share it. So please do come and join us on those two pages and like we say, get the chatter going and support each other. So I just want to finish by saying that my ET is very well controlled. I live a very full and active life. I love working for MPN Voice. It's fantastic and I love being involved with all of you. And I just want to say that this is the reason that I go out 3 times a day and get my exercise. This is Bart, and he's just fantastic, and so are all of you. And I just want to say that I hope to see some of you next year at the in-person forums, because I do miss doing them and it's great to see all of you. And thank you very much for listening to me.
Thank you, Maz. Hi, everyone. My name's Mark, and I'm pretty new to this whole party. In fact, sort of about December last year, I'd never even heard of MPNs. So I'm in the Navy. I've been there for about 30 years. I'm an air traffic controller by trade at the moment, and we're subject to kind of yearly medicals. I had my random medical in December. I went for a cholesterol test, which they do quite routinely. The young medical assistant who was doing it, she ticked the wrong box, I think, on the actual test itself. So I got a complete blood count. About 2 days before Christmas, I got a phone call from the doctor saying, you seem to have found something abnormal about your blood. You've got too many red blood cells, might be an issue. We'll have a chat in January. So I got Christmas to do a bit of Googling, which I did quite prolifically, and found literally everything that could cause anything to do with red blood cells. Went in beginning of January and gave some blood for a JAK2 test. They told me it was a JAK2 test, so off I went again to do some Googling. Then I did a job change. I went to join one of the new aircraft carriers, HMS Prince of Wales, down in Portsmouth in the middle of a pandemic. So I went down there, all the medical staff on board had disappeared off to do kind of COVID pandemic stuff. So I was kind of left on my own for a while. We've all forward the clock to about Easter time. I'm still waiting. I'm still trying to contact the Navy medical people to say, have we got a result for this test yet? They hadn't. Have I got a haematologist appointment? And we hadn't. And in that sort of time, I was having these kind of weird occurrences. I'm quite a fit and healthy person. I'm not overly burdened with symptoms, but I was getting these weird zigzag things along with my eyes. And then it started getting a little bit worse, much to the stress of my wife while I was driving. I had a little bit of temporary blindness in one eye, kind of shutter come down, went back up, all was fine. I kind of possibly ignored it for a little bit. It may well have happened once or twice, maybe 3 or 4 times. Still trying to get in touch with my doctors to find out what's going on. And then when we got to about April, I found out that the JAK2 test had failed. It didn't have enough blood. It was on my doc. Someone should have noticed it, so I better do it again. So had another blood test done, my haematologist appointment came through, and yeah, about the beginning of April-ish, I went to see the haematologist. She sat me down, said, "You're JAK2 positive, you've got a thing called PV," handed me a little guide, mentioned something to do with cancer, told me something about bloodletting, and sent me on my way. I went back to the ship and told them. They were horrified because the ship was about to sail, so they landed me from the ship and sent me to Somerset. And now I kind of sat waiting. Eventually, the venesection started. It wasn't overly high, I don't think, hematocrit, but it didn't come down very fast. So we're still going with that one. We managed to get it down to about 41, then it immediately fired back up to 48. So that's as yet unresolved. I did mention my eye thing to my doctor. He got super excited. They panic about stuff like that when it comes to air traffic control. So they removed my controlling category, sent me to a TIA clinic where I got ultrasounded and MRI'd and echocardiogrammed. Literally every test that come back seemed to throw up something new to have a discussion about. So that's the kind of territory I'm in at the moment. Whilst that was going on, and I wasn't getting a huge amount of information, my Googling proved relatively fruitful. And I found MPN Voice's website, I think was the first thing I found. That kind of led me to the Health Unlocked. So I had a little look at that, and that was really quite helpful because it realised I kind of got to see, because some of the Googling you do says that, you know, there's life expectancies for like 4 years. That's quite worrying. But then you go to the Health Unlocked website, the forum, and you see there's lots of people living to a ripe old age and that have had it for decades. And that made me feel a lot more comfortable. Stress levels went down, and it was fantastic. So I thought, you know what, I've got a little bit of time on my hands. I might as well reach out to MPN Voice, see if they need any help. And I did. So we had a little meeting. They asked me if I knew anything about social media. In the military, you kind of don't use it that much. It's frowned upon because if you use it too much, you tend to end up in the news or something. So I'd kind of removed myself from most of it. I had a presence, but it was mostly removed. And most of that was to do with yoga teaching. So they said, could you be a social media person? So I very rarely say no, so I said yes. So that's my little link into the slide that you're probably looking at now for social media. So our presence at the moment is, we've got Instagram, we've got Health Unlocked, we've got Facebook, we've got a Pinterest page, which I'm just starting to develop. We've got the YouTube channel, which does quite well, and we've got Twitter and the website, all of which we're trying to tie together with a plan. We can go to the next slide, please. So they named me a social media strategist. So what is that? If you look on the left-hand side, that's what people see. We put up some nice little pictures, put a little story underneath it, post it, and everybody presses like, and all's good. On the other side of it, what you probably don't see is there's things called hashtags. They make a difference. People write them at the bottom, and they're really important when it comes to social media, because they start creating a presence, they start creating a group, and they start kind of pulling things together, make it easy to find. I spend a lot of time now creating content. There's tools that we can use which help us out, and it helps out with things like copyright and using other people's photos. Luckily, that's relatively easy now. So we add that to the scheduling and planning. It's really hard. People just think they just quickly go on there, write something, smash it out, and everybody's happy. But the problem is you sit in front of your computer and you think, what am I going to post today? And you have to keep this thing going. You have to feed the beast, I suppose. If you don't, you drop down the pile. The algorithms don't help you. People don't see you in their flows and their streams. So what kind of happens there is, when you've got something important to say, people don't see it. So you have to keep posting and feeding that beast. The only way you can do that is by scheduling. So we put together a schedule and we try and plan ahead so that at the beginning of the week, I know what's going to be going in. This week was a good week for me. On Sunday, I had all of the posts done that are up until Saturday. So everything's dropping in at about 9 o'clock every morning, which is a good time to post, I've noticed. Then it's already there. It's already online, ready to go. It just drops in. I've forgotten it because my short-term memory seems to be terrible these days. And I look at my phone and go, I put one in. Thank God for that. A lot of design work. The copyright's more to do with writing what we're going to write on it. And there's a lot of background research. Not only have I had to relearn social media, and Maz will probably nod at this, Facebook keep changing their kind of their GUIs, their user interfaces. So every time I log on, it's literally different, and you have to relearn it about what goes where, on what page, how you can actually, because my phone's telling me all the time that people are liking things, they're commenting, but it takes a little while to find the comment and then work out how you're going to comment as part of MPN and not myself. So we'll move to the next slide. So a lot of this really does come down to keeping an eye on the social media and seeing what's happening. It does help us. There's a lot of analytics that we can pull from it, but just to go through a couple of them, on our Twitter, which I've not really touched until the last few days, we've had 7,000 impressions. That means 7,000 unique people have seen what we've posted. There's only about, I think, 126 followers, but we've had 500 visits to that Twitter page. Facebook is gusting at about 14,000 now, its reach. So in the last 30 days, 14,000 people have seen what we've been posting. That post engagement, that means people that are actually clicking on something, they're liking it, they're commenting, they're going to the links we've got on there. That's up to about 8,000 at the moment. About 2,600 likes. We got about just shy of 3,000 followers now on Facebook, and the page was visited at least 1,000 times in the last few days. So it gives us all of that. What I do is I post, I look at what's going on, and then we try and work out what sort of things are interesting, what things people don't want to see. It tells me if people delete themselves or unlike a page, so which is very disheartening. But luckily, it's quite low at the moment. Then we've got Instagram. Instagram, we were quite new to the Instagram game, so we only kicked it off 20-something days ago. We've managed to claw ourselves up to about 160 users, about almost 170, I think now. So it was relatively easy to start with. Now it's starting to slow down, but we've just got to keep churning out the posts. I think I've done 27 posts and 36 stories on Instagram alone in the last month. But it's starting to pay fruit. People are starting to see it. It's obviously appearing. And now I'm looking at ways that I can link with other organisations. Pinterest is a longevity thing. Things go into that. They sit there for years and people can keep seeing it. So I'm working out how we develop that one. At the moment, we've only got 8 people that watch it. But out of that, we've had 70 people visit the little Pinterest site. And those statistics you look at on the screen, those graphs, that's the kind of thing I'm looking at. And it's all live data to me. Slide. Another interesting statistic is the audience. So this kind of is interesting. Instagram and Facebook are almost exactly the same. And looking back earlier on in the forum, I noticed that when you looked at one of the studies that you did, and it was like 80% women, I think, something like that. And I thought, oh, what if we advertise that on the social media? Because that's the kind of people that we've got. It's 80% female, 20% guys. If you look at the age, most people are kind of 35 to 44, well, above 44. And that's the same on both platforms. So that's quite an interesting statistic. So I'm aiming to try and bring that age down. Instagram's slightly for younger people generally. Facebook's gone to the older generations a little bit now. And we've got to try and work out ways that we might be able to use that to advantage to target the people that we want, because effectively we want to get that information out there. Slide. So where are we going? I need help, and not help as in only someone to specifically come in and start logging in and posting for me, but I need content to post. I'm using the website. I'm trying to make sure that all the content that we post is accurate, and it's been well looked at, so that we make sure that people are, it's the kind of, we want to try and become the go-to place for people to get their information. There's other streams that we can use. I'm looking at opening or setting up LinkedIn, because there's a different type of people on LinkedIn, and it's more professional based. So we might be able to get some help from that. Pharmaceutical companies would spring to mind. And on the other end of that spectrum, we've got TikTok, because that's where all the youngsters are now. That's where the people that are kind of below 25. But I'm not really that demographic, so that's the sort of place where I need help. Social media is very much going, all of the platforms are moving to short form video content. So short videos, which are highly addictive, incredibly entertaining, but don't live for very long. And that's kind of the way it's going. Facebook's about to start doing that properly. Instagram's already done it with its Reels. And all this is kind of stuff that we have to learn as we go along. So I need help. Maz is doing a fantastic job with the fundraisers. I steal a lot of their stuff so that I can post it. I could do with more of that. We're going to move into getting the professionals to give me a little insight into what they're doing, maybe a blog. I know Claire's going to give us some help with that. I want to see some researchers, a day in the life of a researcher, what you do. I've noticed that looking at all, the ones that get real traction are the ones that either talk about people's symptoms or diseases, or talk about things that they don't know, people stuff that they don't know. So we really want to kind of dive into let's learn about each other, the symptoms, the diseases, how it's working, and the professionals that work with us, because it's all interesting. And all of that allows us that when we want to push out an important piece of information, people just see it in front of them. It won't be sat at the bottom of a feed somewhere. That completes me.
Well, that was amazing, Mark. Thank you very, very much. Fantastic. And thank you for everything you do in your job, your normal day job as well. And I understand you've got big interest in yoga, so maybe we can also get you to come talk about that, because that's a treatment and a way of managing disease and symptoms that we've also been looking at. So I know because of all the fantastic content we've had, we are running over a little bit, but our proposal, just to let everybody know, is that we will move the comfort break to 6:50. And just shorten a little bit the panel session and shorten a little bit breakout groups. But you are free to go and have a comfort break whenever you like, except anybody who I want to ask a question of. So now we're going to do the panel session, and I'm really grateful to most of our speakers for staying on. I also want to just make a quick announcement. We did have a small technical issue with Zoom in the first part of the forum, so really sorry for those people who couldn't join, and also sorry to Alessandro, because you had a bit of problem joining, which was a bit stressful too. So I'm going to allow 5 minutes on COVID questions only, because I think we've done a lot on COVID at the beginning of this session. I know lots of people did submit questions. I've got a list of them. I can see some that have gone in the chat. So first question, I'm going to ask Patrick, actually, and then I might ask Alessandro as well what you're doing in Florence. So question is, should I get an antibody test, Patrick? And how do I interpret it?
The answer to the first question would be certainly yes. We've seen from the data that I presented that the outcomes in people prior to the implementation of vaccines were worse in patients with MPN than in the general population. And we know from the data from the vaccine studies in the healthy individuals that vaccines are very effective in the healthy individuals at preventing infection. What we now need to know is whether the degree of response that MPN patients are able to generate provides that same degree of protection. So how to interpret the antibody test? Well, at the moment, we're working a lot on that. And as we've mentioned, we're combining data. So there are two aspects of the data, essentially. We look at the laboratory data, which combines the antibodies and the T cells that we've discussed at length. And also the probably more important side of things is the real world data, as we call it. And this is whether these markers that we pick up in the lab are actually preventing patients from developing infections. So we really need to marry these two sets of data together to really give us an answer as to what degree of protection is offered from the vaccination in our patients. But there's promising results from vaccination studies to date already, so we're quite hopeful that patients with MPN will be able to mount a good response to the vaccines.
And Alessandro, can I ask you, in Florence, are you doing antibody tests on your patients as a routine, COVID antibody tests?
No, we do not do it as a routine. Clearly, this may be different from site to site. It depends on local rules and also the plans for having additional doses of the vaccine. So we do not do that. There is some information in the literature that the response of patients with MPN in terms of antibody titers may be not for all, but for most of them may be not so good as for healthy people. But actually, we go ahead with the vaccination as much as possible and do not test as a routine antibody levels.
In the UK, actually, some private laboratories are offering antibody tests, and the government is now going to start offering a random selection of people when they go for their PCR test, an antibody test. So I think probably the main message is we don't really know how to interpret them. And even if you do have detectable antibodies, you should still be cautious. But a good way of getting an antibody is to have a vaccination. So Donal, could I maybe ask you to comment on effectiveness of vaccines? Because I know that Patrick summarised the data. So what would you say about the effectiveness of vaccines for patients? Mainly the questions are focused on the different treatment, not the disease type.
Sure. So I think there's probably two parts to that question. So that many of us have been offered different vaccines, and that clearly has been looked at in the study that I presented in the UK, looking at different scheduling. So I think whatever licensed COVID vaccine that is offered, we should proceed with that, and we'll learn more about responses and scheduling and the period between the injections and mixing up the vaccines as regards benefits for all of us. As regards different treatments, I think we've much more to learn. We know that a lot of the agents we use in the non-trial and trial setting in MPN may affect the immune system, some more than others have a very more immunosuppressive effect, like the JAK inhibitors. But still, as Patrick has shown in our studies from guys, we're still seeing immune responses that are heterogeneous. So I still think we should keep having this conversation as we're learning more data.
Great, thank you very much. And there's no evidence that particular therapies are associated with less ability to form antibodies at the moment, but we're still looking, aren't we?
Exactly.
So that I just want to ask you a follow-up question then, before moving to Jamie with a question, because there's been lots in the media about blood cancer patients, and MPNs are a kind of blood cancer, but there are about, I think, 40 different blood cancers, aren't there, that we've all had to learn about. So somebody has very kindly pre-submitted a question saying, which is an important one, are blood cancer patients all the same when it comes to COVID vaccines and their response?
Yes, I think the answer is definitely no, based upon the disease type and how it affects the underlying immune response. And secondly, the intensity and types of therapy that are used across blood cancers vary really significantly, with some of them completely abrogating any immune responses. And that's particularly the case for some patients with lymphomas or myeloma who've had many lines of therapy, where the attempts to mount an immune response to a vaccine is low. So the answer is we can't correlate from that data how someone with an MPN will respond to vaccinations, because it's a very different underlying immune system and a very different set of treatments.
Okay, great. Now, Jamie, I wonder if you might just talk to people, just give us 2 sentences on what a physician associate is, because that's a new role that probably people might not know about. And we've been lucky enough to have you as part of our team for a while now. And then I just wanted to ask you about vaccines and blood clots, and particularly for MPN patients, please.
Yeah, sure. So yeah, hi, I'm Jamie. I'm a physician associate, also known as PAs, which sometimes get confused for a secretary, but we're not secretaries, thankfully, as some of you might have seen me in the clinic with you. Essentially, we are not doctors, we're not nurses. We work alongside the consultants, predominantly trained in adult general medicine, focusing on like cardiology, respiratory, gastroenterology, and maintaining like the very generic skills. But we then apply to work in a specialty, and we stay in that specialty lifelong, hopefully. And obviously that brings benefits. It means that you've got somebody who is working alongside the consultants in a team and it isn't changing specialties. So you might notice some of the doctors rotate around. You might see one doctor one year, a different doctor in a few months' time, and that's part of their training program. We're not doing that as PAs. We're staying in the same clinics, we're staying working with the same team, so we get to know our patients very well, we get to know the side effects of treatments very well, and we're able to build that relationship with the patient. We also stay at like the intermediate level, so often on our daycare unit, I'll go and see patients that I've known from the clinic. I'll be able to do bone marrow biopsies quite well because I do them quite often and regularly, so that's a much benefit for our patients because they're less discomfort, I'll say. So, you know, there's lots of benefits for the patients because I get to know them really well. There's benefit for the consultants because they've got someone around that's around all the time. So yeah, we're up and coming. There's lots of us around, and you might see me and my colleagues around in the clinics. And we're quite proactive in telling you I'm a PA, just so you know who we are. In terms of the vaccine-related thrombosis and obviously thrombocytopenia, so low platelets, I guess the first thing to say is we see a fair number of patients with a low platelet count after any kind of vaccine. It's not unique to COVID vaccines. We have lots and lots of patients who have like flu vaccines or other vaccinations and have a low platelet count following this. The difference with the COVID vaccines is that it seems to be an association with blood clotting in a minority, and I do say a minority of people. It has been mainly associated with certain vaccines. Initially, there was lots and lots of concerns about this. Anybody presenting with any kind of headache, any kind of swelling was immediately thought this person must have a blood clot. And actually, the more investigations we've done, the more things, actually the incidence of that is quite low. We're still seeing people with low platelets, but actually the incidence of having a blood clot associated with that is actually quite minimal. And from our questionnaire that we did, we had almost 1,000 patients with MPN, none of which reported they had a thrombotic event after their COVID-19 vaccine. So that was obviously really, really reassuring. And that's something that I'm discussing with our patients in the clinic.
Great, thank you very much. So I think this is probably the last COVID question, and this is going to Claire Woodley. This is a question, two questions. One, how cautious should MPN patients be now when socialising? And should we, for example, wear a mask in a shop? And if so, what type of mask?
Hi. So in my experience and what I advise patients is that I would say to patients is still to take the caution. So, try to avoid crowded indoor places if you can. Limit your interactions with large numbers of people. So kind of not mixing with huge numbers of different types of people, but know who you're kind of interacting with. Face masks, I think, for me, if I still go into a shop, I still wear a face mask. And I'm wearing the normal 3-layered face masks when I go into shops. So, I think a lot for patients, you have to do what you feel comfortable in doing. And I think I still see it, particularly when I'm out and about, you still see a lot of people that are wearing face masks when you go into big shopping centres, when you travel on trains, people are still wearing face masks. So, I would encourage that if you're going to an area where you are expected to come into contact with lots of different people, then you should wear a face mask.
Great. And you will still notice in the hospital, we are all still wearing face masks. And if you come into a hospital, you will still be asked to wear a face mask, if possible. If you're exempt or you can't wear one, we would encourage you to wear a face visor. Okay, that's it on COVID. It's banned now. It's banned in my house as well. So, Alessandro, I would really like to ask you a question. Somebody has also posted a question on a report that was placed in another patient advocacy group that I know both Alessandro and I contribute to, which is MPN Forum. And Zen, who writes those articles, the question is about an article which talked about Jakafi, the other face. And this is posted actually by a PV patient who's taking ruxolitinib on a clinical trial.
So, that the original name of JAK2 came from the fact that the Janus kinase is an ancient gold of Roman and ancient Greek, and this was described as having two faces. And so JAK2 has two faces because the protein has a part, is a domain that is active and the other one that is inactive. And what was discovered is that this mutation was not in the active part, as all of us could anticipate, but it was in the inactive part. And so from this is the two phase of JAK2. So clearly in the daily life and in the life of any cell of the body that expresses JAK2, the two phases means that this protein is involved in so many activities that some of these may be beneficial and some others are not. And so when you use a JAK inhibitor, that unfortunately we do not have inhibitors that are specific for the mutated protein, but they target just the activated protein. That means that they target both the mutated and the normal protein in the same cell that can express both proteins. Well, you can have expected and wanted effects in terms of control of symptoms by targeting the inflammatory pathways, reducing the spleen. We do not know yet what is the exact mechanism, but also unwanted effects, side effects. And among these, for example, the increased risk of developing anemia and thrombocytopenia because you block some activities of JAK2 and the JAK pathway that are required for normal production of red blood cells and platelets, and also an increased risk of infections because you block some signaling, some responses of the cells that are important for defending us from infectious agents. And so this is why the double phase of JAK2 is a way to interpret the complex world of the normal and pathological activities of the JAK protein, but also the impact of JAK inhibitors.
That's great. Thank you very much. There is also a question about skin cancer and JAK inhibitors and whether interferon might be a good treatment for myelofibrosis. I know we generally say we don't answer individual questions, but any comment about skin cancer and ruxolitinib? From you, Alessandro.
Okay, sorry. Yes, so there's clearly, when I mentioned the side effects of JAK2 inhibitors like ruxolitinib, one is the defense against infectious agents. The other is, of course, the fact that the immune system is involved in the control from other neoplastic diseases. And we know from the results of clinical trials, and this is particularly true for patients with polycythemia vera who have been treated for many years before receiving ruxolitinib with hydroxycarbamide, that there might be an increased risk of developing skin cancers. So this is true because we have many data in this regard. Of course, you have to make a balance between these risks, usually are not aggressive cancers, and what you expect from the treatment. But in any case, you have to recommend serial dermatological assessment in order to follow one patient. And of course, if the case, we have cases of patients who have developed multiple skin cancers. And in that case, you have also to question yourself if it is appropriate to continue or not using it.
Okay, that's great. Thank you very much. And Mary Frances McMullen, I'm hoping you're still here. I wanted to ask you a question about different hematocrit levels. So the question is, why do different hematologists set different hematocrit levels as a baseline? And how do I know mine is right for me? You wrote the guidance on this.
So the evidence is all for keeping the hematocrit below 0.45 in men and women. There is nothing to differentiate. It has been written in the past that women were not small men and should have a lower hematocrit, but the studies all looked at a hematocrit of 0.45 across the board. The only other issue is in pregnancy. If somebody, a rare situation where somebody needs their hematocrit reduced in pregnancy, the hematocrit does fall throughout pregnancy, and then normally, so there you can make an argument for that, for keeping at a lower hematocrit in following across as expected across the 3 trimesters, but that's a very rare situation. Otherwise, as we put in the guidance, it's 0.45. And there's been, I mean, the Italian trial also worked very nicely showing that as well.
Great. So Chandan, I know you're on the line. Chandan is another one of our research fellows. So Chandan, there's a question in that's been submitted about the shingles vaccine, not COVID vaccine, shingles vaccine. Should MPN patients have shingles vaccine? That is routinely recommended, isn't it, for older people in the UK? So perhaps you could comment on that, please.
But shingles vaccine is one of the live vaccines which we generally recommend against in anybody who has got any blood or bone marrow cancers. So we do recommend our patients to have the flu jab or the COVID vaccine, but any live vaccines we recommend against.
That's great. Thank you very much, Chandan. Now, Patrick, there is a question about inflammation and also about data with regard to curcumin and PV. Would you mind answering a question about what we know about the benefits of anti-inflammatory food ingredients and supplements?
Yeah, sure. So I saw this as one of the pre-submitted questions. It's quite interesting because I looked at this in a few years ago in another type of blood cancer in patients with myeloma, and there's certainly some interesting aspects of curcumin. It certainly does seem to have some anti-inflammatory properties. So I did a bit of reading around the evidence in MPN earlier, and I think one of the questions suggested that there was some good data. I mean, there are some studies that have looked at it, but they're very much early phase laboratory studies. Nothing has crossed into the clinical sphere from what I could see. And so whilst it's definitely an interesting compound, and obviously it goes back years in certain medicines, Chinese medicines and such, and there's nothing to suggest that it should be used as an alternative to the medication that we would provide and prescribe for patients. So yes, it does seem to have some interesting properties, and it's worthwhile having a bit more of a look into that and to continue to investigate in the laboratory. But no, it's not something that I would advise to take as an alternative to traditional medicines at this stage.
Thanks very much. I've forgotten you did that and looked at that in myeloma. What I would say is, I think if you want to take supplements like this, and you are taking medication, it is a good idea to let your medical team know and or speak to a pharmacist about it, because there are some medications that can, for example, interact particularly with drugs like ruxolitinib and also anticoagulants. So often Susan, who's one of our other clinical nurse specialists who's on the line, will be asked a question about that. And you were very happy to answer that. Susan, I wonder if you would mind answering a question about what we would recommend with regard to diet and MPN. I think you're muted. Perfect.
Can you hear me?
Yeah.
I am
just
Susan,
about.
One of the other clinical nurse specialists within the MPN team, and eating a well-balanced diet will be our main advice to our patients. Mainly our food choices are very important, because it is the main fuel to our body anyway, to generate the energy and to cope with the disease process as well as with the treatments. So especially our food choices could actually either help us or to put us at risk of developing other related risk factors as well. So what we would be recommending is to have a well-balanced diet. especially choosing more vegetables and fruits, and also to avoid foods that could actually put you at risk of developing the blood clots, especially like cholesterol-rich diets, which in turn can put you at a risk of blood clots. So those are all I mean, it's the end of the day, we would choose what we would like to eat, but at the same time, when we be mindful of the choices that we make, and then to be aware about the risk factors that will be associated, would be best in making those choices. And also at the same time, hydrating very well, hydrating in sense with water, rather than with more caffeinated drinks or with alcohols, because again that puts you at causes for dehydration. So hydrating with water, well balanced with vegetables and fruits, and more of fiber content, so that could generate more energy to deal with the fatigues, and being more cautious and being more aware about preventing other risk factors, and avoiding foods that could put you at risk of developing blood clots.
Fantastic. Thank you very much. And thank you for everything you do as a new member of our team. Fantastic. So Dr. McLornan, I asked you the first question and I'm going to ask you the last question. Actually, this was a question posted in the chat, I think by Jill Thomas. So I'm going to actually ask two questions because I'm fond of doing that. You probably already noticed. So Donal, early treatment for ET preventing progression, question one. And second, is it possible to stop treatment for ET, or must we always continue it?
Yeah, so two really, really important questions that before I answer, it's very important to remember that's very individual based as regards to the answers. So I think the question about early intervention for ET, most of us know that it's a chronic disorder, and clearly intervention is not required in many people for many, many years after diagnosis. Our current guidelines are based on a perceived risk of thrombosis, and that's why we use age and cardiovascular risk profile, which should be monitored dynamically throughout the course as potential indicators for treatment. As regards other indications for treatment that don't meet the guidelines, sometimes, as you will know, we use other drugs would be based on symptoms. Sometimes we don't all fit neatly into these low, intermediate, and high risk groups, but based on symptoms, we may need to think if they're interfering with quality of life based on treatment. My view is that early intervention, not based on any of those factors, we don't understand enough whether that would modify long-term disease outcome. And we need to be aware that the risk of transformation with ET often occurs very, very late in the disease, if it happens at all. And it only happens maybe potentially between 9 to 13% of individuals. So for my own view, would be not for early intervention unless there's a strict reason. Now, I've talked a lot there and I've almost forgot your second question, Claire, which was based on?
Stopping treatment.
So again, it's based on, obviously we can't stop aging. So no, if it's based on age. I think if cardiovascular risk factors were the indication and we're less than the current cutoff age for therapy, and there's potential side effects, we may consider it. But again, that's a very individual based choice and not something that most of us commonly do in the disease course of ET.
The only other context would be just in the context of interferon. So I'm going to chuck the last question to Alessandro as our, and Danny told me I could only ask one more question, so I've been naughty. But Alessandro, we're so grateful that you came and joined us today. So my last question is a question to you because you raised interferon. Can interferon cure MPN?
This is a big question. There is not yet a big answer to that. So we know that unlike other drugs, interferon has some potential to be a disease modifier agent. This is clearly supported by the fact that some patients not all patients. This may be true for about less than 20% of the patients with polycythemia vera, may show progressive decline of the JAK2 amount, the percentage of mutated alleles of the JAK2 gene. And in some patients, the detection of the JAK2 mutation may become zero. You cannot find the mutation in some patients after usually some years of treatment with interferon. So there is some potential to cure the disease, but we have to acknowledge that we are still missing enough data to say that interferon is a curative drug for MPNs. And this may be true again for a proportion of patients with polycythemia vera. We have not enough experience in ET, we have no experience, not enough experience in myelofibrosis, but we really need to understand more and more about the effects of interferon before we can say that it can cure the disease. We know that disappearance of the JAK2 mutation may be something that, of course, supports us in thinking about that, about the cure, but we know that this is not exactly what can happen in some patients that can progress in their disease even after the disappearance of the JAK2 mutation. So this is really a complex story, is a fascinating story that there is a lot of hope after behind interferon, but we still need a lot of experience, many more patients, many more trials.
Okay, sorry to ask you a difficult question. Looking into the future, having asked you to present on history, but thank you very much. So I want to thank all the panel members and all the speakers.
All right, fantastic. I'm going to keep this very, very short and sweet and confine it to basically saying thank you so much to everybody who firstly joined the call today. It's great to see patients getting together, even if it's only over Zoom like this, but it's fantastic. But of course, a special thanks to everybody who made a presentation or did a talk today. It's really great to see everybody being willing and able to give up their time for this and to share their expertise with the patient community like this. Thank you very, very much to all of them and to you all. Any thoughts from you, Claire? Maybe.
I can't hear her.
Claire, are you on mute?
Okay, I knew I'd have a tech problem. No child muted me, which is unusual. Yeah, but just extra people I want to thank are actually Danny, Drew and Dean, who are in the room, who had this all set up early on and have done a great job. And thanks to the team at Guy's and everyone. Please give us some feedback because we want to know more about how to make these useful for you and meaningful.
Thanks again, everyone, and see you next time.
Bye, everyone. Take care.
Bye, everybody. Thanks.